and present and listen to the people involved in a specialty. It's a very good, I think future is based on that. What do you think, Shakti?
Yeah, correct. I think this is one of the things which is changing the market genomics in coming months or coming years probably. So it's a good thing and it's a nice initiative from Chirag. At least we talk on cancer. As Chirag said, it's not very interesting topic,
No,
but
it's interesting. It's sir, I love this topic.
attractive, public attractive. I mean to say, so public will not be that much attracted to these kind of topics unless they face something of this kind with their relatives or anyone. So the important point is now it's a high time that as a doctor, as a dentist, as a super specialty in dentistry, medical doctors, I think we should contribute towards the prevention of oral cancer, because oral cancer it's rapidly prevalent in our country specifically. If you see, there was a publication a few months back that within 3 years the head and neck cancer have increased to 300%. So you can see the load how it is going. I think it's very important. People should aware about it, and we are working on it. And I think this is one of the platform where we are making people aware about the important is early detection, important is prevention, and important is quality of life. I think that is what we are looking forward for it. How to have good quality of life. What do you say, Deepak? Now,
I totally agree to you. Actually, I believe that the numbers and the specialists who deal with such tumors are very comparatively low. And more and more people, especially from a field of maxillofacial surgery, they are trying to get in, and nowadays a lot of them are training also. So this is the new trend. I feel this will become something very different in few years. I believe oral and maxillofacial cancers should be and mostly will be treated by head and neck, exclusive head and neck cancer surgeons, whether they are ENT or general surgeons doing head and neck surgery only. See, I always believed in one thing. There is nothing in any subspecialty which is part time. As you agree, we discussed some things few days back. You cannot have a clinic and do a cancer surgery in the evening. It is something like do a probably a small whatever tooth thing and just say I am a cancer surgeon. It needs lot of reading. It needs lot of training. I mean, I don't know. Probably, I mean, for 5, 6, 7 years, I was training for good 6, 7 years. So it is something which is time consuming, and you are dealing with a patient's life. See, you and me, and probably Chirag and Saurabh, all these boys, we deal with something which will not cause a loss of a tissue. It's going to cause a loss of a body as a whole. COVID hits you, you might survive. It's just 3% mortality rate, but bloody cancer hits you and you're not treated well. No way anybody can, save you. You should know how to treat these patients. You should know how they should be treated. And the guidelines, you and me, when we were doing IFHNO training, we have seen these guidelines. And I was shocked to know that 99% of the people, or 95 probably, don't know even the guidelines, who say we do tumor surgery, any kind of tumor surgery. So it's a good thing, and we are thankful to young people like Chirag and team, who has given us this opportunity, and we'll try our best to help youngsters and budding surgeons and all, so that, and even general practitioners, this cliche of cancer and headache and depression, it has to be broken. There's nothing depressive about cancer. If somebody has a disease, it has to be treated, and we will prove today probably that it's not that bad. So that's what I think about it. So Chirag, I think it's sharp 4. How many people? Can we start slowly?
Sir, I feel on my screen it still shows 4 minutes left.
Okay.
And
Yeah, 4 minutes left. Yes.
yeah, people are joining
All
in.
is going
Okay. Okay. Okay.
fast.
Okay. Okay.
Deepak sir is Deepak sir.
Hmm.
I lose hair, man. Waiting, Chirag. More, becoming bald day by day.
Hmm.
Shakti, who does your beard, man? Like, the way you keep it, it takes a lot of effort.
It's self-artistic.
So we are finding it difficult to cut hair nowadays, and you're still able to, maintain this thing. It's phenomenal effort, I should say. Most of the people nowadays I'm seeing they're just shaving. They're fed up. So nobody wants hair. So I see suddenly bald, and you get scared because when you see bald in our culture, it means a lot of different things.
Yeah.
So, but then you ask them what happened. They're like, nothing, nothing. There was no barber and we don't want headache. So, ajkal, bald is the new in, I think.
How is it?
Yeah, you're saying something?
Yeah, how's the condition of Mumbai right now, Deepak?
Oh, it's pathetic. Like, it's like a warlike situation. We have lot of population and, we have whatever infrastructure is there, it is under lot of pressure. So people are doing whatever is possible, but we are almost at the brink of, you can say 95% occupancy of hospitals.
Mm-hmm.
So big problem. So I hope so. It becomes better in few months or whatever time.
Mm-hmm.
It's not good, that good, in Mumbai.
Mm-hmm.
Ahmedabad is okay now. Gujarat is better.
It's more or less, I don't know, because I don't see any news or something like that. We are just coming from office to hospital, hospital to home. So, I don't know. But yes, our patients are being COVID tested before we take off a surgery. So that is the protocol is being formulated by Apollo Hospital that every patient has to undergo a COVID testing
And
before
what
we.
Okay, and what if he becomes positive later on after 4 days?
No, probably we all have to undergo quarantine for 2 weeks.
Okay.
But it's all, we are thankful to God that we have not yet had any patient who has been positive after surgery in last 2 months. So,
Okay.
but yeah, pre-operatively there was a patient. They are kept in isolation and we do the COVID testing. So that patient became positive, and our residents, they were quarantined for 2 weeks. One of our residents is quarantined for 2 weeks.
Yeah, so most of our colleagues who are doing general practice and specialists, there are a lot of videos and articles coming on what to do PPE. I don't understand why it is so important PPE. Basically the concept is just to cover your eyes, nose, and mouth. All right. So,
Yeah.
so eyes, nose, mouth doesn't mean you go under a bulletproof kind of a situation. You where you covered from head to toe. You just have to cover three parts, and you wear your normal whatever gloves and do your work. And only thing is you have to be a little more careful and make sure that you don't touch your face once you finish your patient, especially the general practitioners. So a lot of chaos, lot of this thing, but that's how it is right now. And I hope so this situation becomes better. It doesn't looks like that, but probably in few months I hope so things are a little better, at least at major Delhi and Bombay and all that. Bangalore is also okay, I feel now. So there is nothing great about PPEs. If somebody is listening to us, PPE is basically a personal protection kit. Somebody just makes a video of sitting in a clinic and just talking about it. There's nothing to talk about it. You have to just basically cover your eyes, nose, and mouth. All right. You don't need to get fully covered, drenched in sweat. And we had some cases people dying because of that. So because of asphyxia and breathlessness, and one guy got a heart attack. If I'm not wrong, some guy got a heart attack and all because of that. So yeah. So don't put so much pressure on you. Be okay. I mean, see, it's just a virus with 3% to 2.85% mortality rate. So you have to be extra careful. Wear normal protection. Do your patients. Try to wash your hands after each patient. Again, keep some, I think, gap between appointments and then attend the next patient. What do you think, Shakti?
Yeah, right. You're very, I mean, you are right that we need to take adequate precaution, but especially our work, especially the cancer work, we cannot postpone because Corona is not going to stay for 2 weeks or 3 weeks. It's going to be a long fight. So probably we need to be very overcautious. At the same time, we need to keep our services, continue as how we were doing earlier, because cancer doesn't give time to anyone. Probably we have seen in this COVID times, there are a lot of patients who have been upstaged in this time because they couldn't reach on time.
Yeah,
So these
and
patients are going NACT, or probably they are not operable also. It's a big problem for us, people like us who are operating on oncology. And it will take time for them to reach to the hospital. By the time they reach, they will be on an advanced stage. So here, an important thing what we all should do is we need to train our people so that if they are sitting in any part of the country, they should be able to diagnose patients on early stage and guide them for the proper treatment. For a patient to reach to Mumbai or Ahmedabad from a periphery, I'm very sure that patient will be upstage to, from stage 2 to stage 4. So it's our professional duty, our moral duty, that we should be putting an effort now for oral cancer diagnosis, keeping our eyes and ear open whenever we are examining an oral cavity. It is very important. You should look for any symptom of oral cancer or precancerous. In case of any symptoms, you need to direct the patient in the right direction for biopsy or for consultation from a specialist. So I think if everyone is listening to it, it is everyone's job to be careful and read about cancer, read about oral cancer symptoms. Just see some videos of it. You can always connect to me or Deepak or anyone, those who are working in oncology. We can definitely guide you for for oral cancer symptoms, because your eyes cannot read what your mind doesn't know. So it is very important that you should be well read. Before well read, then only you will be able to diagnose, screen a patient at a very early stage. My boss used to say only one thing: the treatment for cancer is early detection. We are doctors. We cannot probably do wonders to save a stage 4A patient. We cannot give a longer survival, but yes, of course, we can give a better survival and a very good quality of life if we operate on stage 1, stage 2 patients. So that is what we are looking for, and that is what we expect you all people who are today with us, that you need to learn. Deepak is going to tell you about it, that how you diagnose the oral cancer patients on an early stage. So it is very important for us to give, as a professional, again I say, professional and moral responsibility, be the part of the commando force against the fight against the cancer.
Okay. So, Deepak sir,
yeah,
if it's okay, can we start now? We have around 70 people and people are still coming in, but I think it's time now.
okay.
So, okay.
Chirag, you have to. Can you move my screen, or I have to do it? Because
Sir, you will have to do it.
Okay, I have shared it.
Yeah.
But this thing is not moving. Okay?
Yeah, now it will move. Hello.
Hi, Parth.
Yes. Yes. Yes.
Chirag, can you move this waiting room from my screen? I mean, it's just coming in between. I can't see anything.
Yeah, just a minute. Suppose webinar. Hello. Sir, क्या करना है? Sorry, I didn't get you.
I think, Chirag, I'm not able to move my slides. You have to remove this waiting room is just right in my center of the screen. So you have to move.
Side में कर दो ना आप.
Okay, I'll just stop sharing and again I'll share. Wait.
Just share again. Yeah, now is it better, sir?
Okay, let's see. Yeah, all right.
Okay.
So I cannot see. Chirag, you just have to minimize the entering window, waiting room. Okay, you minimize it and keep it.
Sir, उसको side में रख दीजिए because वो minimize नहीं हो पाएगा because people are coming in ना continuously. So even if I minimize it, it will keep on popping up.
All right. Again, but it is getting locked. Right.
Okay.
चिराग तो ऐड कर रहा है वो लोग को कि मैं भी कर सकता हूँ?
पार्थ तू भी कर सकते हैं.
हाँ तो मैं कर रहा हूँ.
Yeah.
You can move my slides.
So did you accept the screen share?
Yeah, I have accepted.
Okay, you let me know.
Okay, now it's fine. Okay, so welcome everyone. Today we are going to talk about tumors in the oral cavity, especially cancer means bad things. Cancer is dangerous, and cancer is something which causes a lot of harm. Well, which is true to some extent. And for that reason, we should be knowing the basics in the management of oral and maxillofacial tumors, especially with respect to cancers. And right from the patient enters your OPD till the patient has a treatment plan in place, it's the responsibility of the clinicians to make sure that whatever they prescribe to these patients is according to global standardization of treatment. So I thank you, Chirag, Parth, and my colleagues, now, first students and then now colleagues, to give me an opportunity. And I welcome Dr. Shakti, a very, very good reconstructive and head and neck maxillofacial surgeon from Ahmedabad also. So we'll try our best to help all of you. And at the end of both the talks, probably, Chirag and team can take questions and then we can, proceed from there. All right. So let's start. So this is something very funny, so whenever some patient comes to us and we do not have any idea, like, what is it all about? We try to beat around the bush. So this patient is asking, the brain tumor is incurable. So the doctor says, I can give you something for your dandruff, So, which is totally not related. The patient's concern in cases of oral cancers is a non-healing ulcer. And you will not believe that most of our patients, especially in the Asian subcontinent, these patients who come to us, they come to us at an advanced stage just because of the fact that somebody doing general practice or somebody who is a physician or whoever, somebody who doesn't know or who has a little less knowledge about these non-healing ulcers, was giving them a prolonged dose of multivitamins, a prolonged dose of what you call it, some kind of antioxidants, and a prolonged dose of all kind of things for that matter. So when you're talking about head and neck cancers, what are we talking about? See, head and neck is a very, very vast stream. Let me tell you that. So head and neck has got various subsites in that area. So we are talking about oral cancers, oral and maxillofacial tumors. We are talking about orbit and orbital tumors. We're talking about the voice box tumors. We're talking about thyroid tumors. We are also talking about skull-based tumors. Not to forget about tumors of the skin of the face. So it's a very vast field, but being into maxillofacial surgery, we usually deal with salivary gland tumors, sinonasal tumors, orbital, as well as the scalp tumors. So we will not go into all those things. We'll restrict our talk to oral cancers and oral and maxillofacial cancers so that at the end of the talk, most of us do understand the basic guidelines how to manage these tumors. So we have a patient who comes to us sometimes with a lesion, sometimes with a biopsy, or sometimes both, Obviously, he has a lesion and that's why he has a biopsy. So how to approach such patients? So first thing is that you have to yourself stay calm and assure the patient. When a doctor herself or himself is not calm, the patient becomes uncalmed 10 times. Okay, so we usually get calls from different doctors all over India. Doctor, I got a patient, he's got cancer, and the patient is just in front of these people, which is very, very scary for the patient. So you have to be very calm, you have to be very polite, you have to be very kind of peaceful in making them understand there is a problem which can be addressed, and this problem needs to be addressed as soon as possible. So staying calm is very, very important. Chirag, still this waiting room is right in the center. I can't see much in my slides, because of this. You have to, plus I can hear all the notifications. Can you do something about it if possible? So when we treat these patients, what are we looking at? So whenever you treat cancer patients, you have to follow certain guidelines. Now, where are these guidelines available? Well, they are available on the web. They are available on the sites, which are standardized sites for the management of oral cancers or head and neck tumors like NCCN and all those things. You have to look at articles which are multicentric trials, basically a level 1 evidence or a level 2 evidence, which talks about formulating the treatment modalities in various pre-malignant and malignant lesions of the oral cavity and the maxillofacial region. It's very unfair that we have been taught in such a way that we believe that whatever books we were told to go through had abundance of literature knowledge and we should just follow them blindly. Well, it's totally wrong. Most of the authors which have written those books are dead, like they don't even exist, and these are upgraded by some agency or whatever, who knows who upgrades them. And most of the times the textbooks which were written long term back or a long time back, they are very, very kind of insufficient when you talk about the modern day management of tumors. So always supplement these textbooks with literature which is available freely on the internet, or ask the experts who are doing these tumor cases day in day out. There are a few doctors who have dedicated themselves to the treatment of oral cancers or oral and maxillofacial oncology. You can give them a call, you can mail them, you can send the reports, and these are the people whose words you can take it for seriously. Rather, the others, I mean, I do not believe, we were just discussing for that matter, you cannot do a tooth extraction probably in the morning and do a tumor in the evening. You have to be 100% dedicated. You have to be 200%, your mind, your body, your soul, all has to be totally involved when we are talking about patients with head and neck cancers. So what are the different aspects of these head and neck cancers? See, I'm not going to talk about anything which is boring, which is outdated, which is written or blah, 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 because I myself don't like those things, and they have changed, most of them. So I'll be only talking about the clinical aspects of these cancers. I'll be talking about things which actually make a difference, so that you can put all these things in your practice and help your patients accordingly. So what are these things? So in the history, for example, what is most important in the history? So whenever you take a history, you have been taught, ask the patient, where does he live, what does he do, and all that. See, when you're talking about a history of a patient who has a non-healing ulcer or a lesion or a swelling or a lump in the neck or whatever, this history is not important. Where does he live? Probably to some extent when we are talking about occupational cancers. Oral cavity usually doesn't has an occupational cancer as such, as in, I mean, they're definitely not with respect to stress, but per se arsenic and wood and all, they mostly cause nasopharyngeal tumors or oropharyngeal tumors or lung cancers or laryngeal cancers. So with respect to smoke, I'm talking about. So when you talk about oral cancers, the history has to be, and you have a patient having a lesion, history has to be very crisp. You have to ask about the habits, which is very, very important. Habits per se are one of the most important thing when you're taking the history. in the habits, the history, what type of consumption he has, what is the frequency of that consumption, and since how long he's been doing that. This is all very, very important. And what comes next? The comorbidities. Is he diabetic? Is he immunosuppressive? Is he a COPD patient? Is he a heart patient? Is he having a renal disorders and where is serum creatinine, and is he on dialysis? See, all these patients, and obviously the socioeconomic status. All these patients usually somehow will be immunosuppressed, and because they are immunosuppressed, what is the chance that they, because their immunity is less, they are more prone to get these cancers. All right. So then we come to examination point of it. So there are two types of, when you talk about oral cancers, you have an intraoral and an extraoral examination. You have inspection and palpation. So what about intraoral examination? Please do remember when you're examining any kind of a patient with a non-healing ulcer, you have to remember that you have to divide the oral cavity into different subsets. You have to check the lips separately. You have to check the buccal mucosa separately. You have to check the retromolar trigone separately. You have to check the anterior 2/3 of the tongue separately. You have to check the posterior 1/3 of the tongue separately. You have to check the hard palate separately, and you have to check the soft palate and the pharynx or the oropharynx separately. So never just because you are tired or you are just not interested, you just tend to put the light in the mouth, and most of the times you cannot see properly also, and you just go and just say, okay, you have nothing. Spend at least 5 to 10 minutes in looking at some kind of an anomaly or an abnormality, which can be a lump, which can be a ulcer, non-healing ulcer, or any kind of deviation from the normal. All right. So this is a very nice YouTube video which I found out for examination of the neck. We teach in a medical college, so a lot of times we see this, that people do not basically know how to examine the neck. So some people just put the hands here, some people will go behind and put the hands, some people will go with their hands straight into the neck. So just we'll have a look.
Sir, you will have to screen share that particular screen.
Can you see the video?
No.
Okay, one second.
In screen share option, select on the YouTube, like the whatever you're using, Internet Explorer or Google Chrome or whatever.
Okay, let's see if I can share this. You can't see this?
No, sir.
Okay, probably in the end, probably, yeah. Chirag. Okay, let's just remind me, huh? All right. Fair enough. So this part, what are you examining in the neck? So you are examining basically the different levels of lymph nodes. All right. So neck has got roughly 7 levels of neck nodes, right from level 1A to 1B to 2 to 3 to 4 to 5 to 6. So when you're talking about oral cancers per se, we are most keen in level 1, 2, 3, and 4. Level 5 nodes, most of the oral cancers hardly go there. The evidence, whatever evidence we have, the supraclavicular or the level 5 nodes, which is just posterior to the sternocleidomastoid or the posterior triangle or whatever you call it, there is only a 1% to 1.5 to 2% chances that these nodes do get involved with oral cancers. So our area of interest usually remains level 1, 2, and 3. Although when we operate these patients, we do clear level 1, 2, 3, 4, 5, all. Level 6 are the midline nodes, which are usually the paratracheal nodes or nodes which are related to your thyroid gland. So usually when you're doing thyroid cancers, you basically try to clear the central compartment. The central compartment, meaning the compartment that is between your two carotids on both the sides. So, or the laryngeal cancers, when you have cancers of the larynx. So sometimes these laryngeal cancers do go to the level 6 nodes and you have to clear them with a functional neck dissection. Very important thing, which whenever I'm told to come to meetings, I'm grilled over it. Biopsy, we have this very unfortunately wrong thing taught to us that biopsy should be taken with the excisional biopsy or incisional? What type of biopsy should be taken first of all? See, when you're talking about non-healing ulcers, the best way to take a biopsy is only and only incisional biopsy. Now, whether you take it with a knife or if you have a beautiful instrument such as a punch, which I have put it as a picture, you can use this punch forcer because it's very easy. And it is very non-expensive. It just hardly uh, costs around $800 or whatever, $100, not $100, I think $10 or $15-20. So this instrument is a phenomenal instrument. You just identify the area of the concern. Now, how to identify from where to take a biopsy and how to take a biopsy. So ideally, if it's an ulcerated, ulcero-infiltrative lesion, you can use a knife, but do not take a normal mucosa. Just go in the area which is most undifferentiated, which looks very, very unhealthy. Go deep and take a nice bite into that area and just submit it, put it in the formalin. The ratio should be 20 times the tissue, all right? So this is how you should match it, and then send it for histopathology. Punch biopsy, why it should not have the normal mucosa? Because when you take the normal mucosa into your biopsy, and when a surgeon excises that, you've already taken a part of the normal mucosa in your biopsy. So, for example, you have taken 3 millimeters of normal mucosa and the edge of the tumor. There is no clinical sense, according to me and according to people all over the world, who operate these tumors, that we do not want to see the normal mucosa. You do not want to see whether the other side is involved or not, because as it is, you're going to later on when you operate these patients, you're going to do the frozen section. You're going to have 1 centimeter margin all around the tumor in all dimensions. So there is no sense of taking the normal mucosa. This has been put in a head, I don't know I don't know who, probably whoever, but this is a very, very wrong practice. You'd never take normal mucosa because it does not help. You just go and do a punch biopsy with a punch or do a knife. You never do an excisional biopsy for a tumor which looks sinister, because if you do an excisional biopsy, first of all, if it's a malignant tumor, it will bleed a lot. So you're in a deep, deep kind of a situation where in your clinic, you do not have a monopolar cautery or a bipolar cautery, and you cannot control that bleeding, and finally you have to call someone. So always take a punch biopsy or an incisional biopsy, go deep, nicely take a small amount of tissue in an area which looks undifferentiated, which does not look good. And this is how you should do it. What type of anesthesia should be given? Next question. See, whatever I'm telling you according to some guidelines. So please, if you have pen and paper or whatever, just keep writing all these things, because it will help you, and at least you can help many patients. Infiltration. Never give local infiltration around the tumor. Why? Because basically you're pushing, for example, your suspicious lesion is a carcinoma in situ. So when you inject with pressure, you're actually pushing these cells into the subepithelial layers in the connective tissue. So you might, by default, cause an upgrade of the tumor. And as a result, when a surgeon operates these tumors, you have to go much deeper at a much lower level to excise them. So better way, there are 2 ways to do a biopsy. One is the spray, and the other is a regional block, loco-regional block. As maxillofacial surgeons, we know all the bloody blocks, these blocks can be used and the whole area can be anesthetized. So what is the problem? You can anesthetize the lingual nerve, you can anesthetize the lingual, whatever lingual nerve, you can anesthetize inferior alveolar nerve. Once you do a pterygomandibular nerve block or a posterior superior alveolar nerve block or a intraorbital nerve block, you can easily take a biopsy. This was about the biopsy. Now, one important question that I am asked many times, and probably for past 10 years. What should you do? Should we divide the sample? You should never divide your sample, because when you divide your sample, you have 2 friends, Tina and Meena, or whatever, X and Y. You send one part to one person, the other part to another person. What actually is happening? What are you doing? Basically, you're dividing your biopsy sample. You're sending to 2 people. Ultimately, one will report it as a squamous cell carcinoma, the other will report it as hyperplasia. You're again in a soup. So always send the full sample to one clinician. It does not matter whether it's an oral pathologist, it does not matter if it's a general pathologist. Just send the whole thing. Do not divide your sample and try to impress just because he was your classmate or a batchmate to 4 people. You're dividing it. You're dividing the sample, you'll get different diagnosis. And you will not be able to treat this patient. You have to call this patient again and again, do a biopsy. So always send the full specimen. Yes, once the report comes and you're not satisfied with the report, what you can do is send the slides for review. That you can do because the slides are already made. So slides can be sent to for a second opinion to see whether the pathologist, the previous pathologist has missed onto something. But never divide your sample. This was about it. So whenever these patients with a non-healing ulcer, oh, sorry, I forgot. When should you take a biopsy? Any ulcer that does not heal for more than 3 weeks, max 4 weeks, you should go in and take a biopsy. Do not keep on treating these patients with antioxidants, multivitamins. Basically, if it's a cancer, you are basically helping the cancer to grow technically. So ultimately, you're not doing anything. You're just wasting the time of the patient. The patient is going to have more wider infiltration, more deeper infiltration, and that will ultimately result probably in a bigger operation later on. So don't keep the patients for 2 months. There's no ulcer which remains for 2-3 months unless it's a tuberculous ulcer or a syphilitic ulcer or blah blah. Other kind of you can say connective tissue disorders, which are very very rare in the oral cavity. So only thing that is not healing and you're giving whatever antioxidants and multivitamins, please think about cancer. And 3 weeks, we recommend 3 weeks is the time when you should call somebody or yourself take a biopsy of these patients. So what should I do, doctor? I have taken the biopsy. What else should I write? Write the routine blood investigation. What should I write? LFT, RFT? No, you have to write what is most important because see, you're preparing the patient for surgery technically if it comes out to be positive. So you can write routine blood, CBC, Triple H, LFT, RFT, X-ray chest, CT, MRI, depending on the subsite of the tumor. See, again, let me be very clear. What investigation, what scan is very, very important. And this is the reason why we are having this talk. So different subsets will require different kind of, scans or MRIs or whatever. For example, one second. Chirag, again, my slides are not moving. Can you just see? So, yeah. So, for example, we are having a lesion in the buccal mucosa. All right. So, buccal mucosa tumor. Yeah, thank you. So, buccal mucosa. This is a phenomenal paper by Dr. Suprit Arya from Tata Memorial and Dr. Prathamesh sir. It came out and they spoke about different subsites. You can take a picture. You can read this. It's a phenomenal article. I love this article because it talks about different subsites. It talks about the imaging modalities in these different subsites in different subsite group for patients. And what does it talk about? In short, I'll just tell you. So if it's a buccal mucosa cancer or buccal mucosa ulcer, CT scan, puff cheek view is the best option. Okay, don't write OPG. It does not make sense. Why you're asking for an OPG? The tumor is just in the buccal mucosa. Now, if it is a buccal mucosa tumor coming into the gingivobuccal sulcus, still don't write OPG because it does not help you. OPG does not tell us about the soft tissue. Please remember that. You have to order a CT scan because you want to see the tumor and its relationship to the bone, as well as you will be able to see the soft tissue involvement. So when the surgeon is planning the surgery, I don't have to send the patient again for a CT scan. What type of CT scan? CT scan with contrast, CT scan, puff cheek view with contrast, along with neck or plus minus neck, it's your choice. What is the best option for neck? See, there have been different trials, there have been different multicentric studies. Most of them have compared ultrasonography with CT, with MRI. My personal opinion is ultrasonography is one of the best modality according to sensitivity and specificity, but there is always a difference of opinion. So somebody will say CT scan. That's okay. Whatever it is, the difference is not much. The only disadvantage of ultrasonography is it's a second procedure. So patient has to pay more. On the other hand, when you're doing an oral cavity CT, you can at the same time do the neck CT. So you save some money there. One more disadvantage of ultrasonography when you're talking about neck nodes is it will only take up the superficial nodes, say 5 millimeter, probably 6 millimeter, but anything deeper will not be picked up. But yes, it is very sensitive, it is very specific. So ultrasonography for the neck, buccal mucosa subsite, CT scan, bucco-gingival-buccal sulcus, CT scan, bone involvement, CT scan. Now, if the tumor is in the floor of the mouth or tumor is in the tongue, what is the doctor best option? What should I order? You have to order an MRI. For tongue tumors, MRI is the best option. MRI will give you a better signal. MRI will tell you all about the dimensions. And the most important thing about MRI, which it's going to tell you is, it's going to tell you the depth of the tumor. So actually, you can plan your treatment according to the depth, because in the latest classification, which I'll show you, the depth of the tumor has become an integral part of AJCC 8th edition TNM classification. So you can go online, it's there in my presentation, and you can basically just click pictures or probably download yourself. Now it's no more the old one. So whenever you're saying it's T1, N0, M0, you have to tell according to the latest AJCC 8th edition. All right, so that is one thing. So according to subsite, according to the area. Now, for example, it's a hard palate tumor. What should I do? MRI or CT scan? Do a CT, because you want to know the bone. So whenever the question comes of whether you want to see the resorption pattern in bone or not, it's better to do a CT. In tongue, there is no bone. Now you have a condition where probably the tumor is so big that it's going from tongue to floor of mouth, reaching right up to the alveolus. Then probably one investigation is more than enough, because in our country people have problem of spending money. So CT scan again becomes okay for this patient, or an MRI. Both are okay, that's fine. But talking about different subsets, whenever you want to see the resorption, whenever you want to see anything related to bone, CT is better. Although the marrow signals that we get from the bone are better when we do an MRI. So whenever you write a CT scan for cheek, for gingival-buccal sulcus, you have to write CT scan, oral cavity with contrast, puff cheek, you wipe puff cheek. You tell the patient to put some air so that the buccal mucosa goes away from the gingival-buccal sulcus, so you do not see artifacts in the scan. All right, you don't see the tumor which is in buccal mucosa is also in the bone. So when patient holds the breath, it helps us to differentiate the subsite. What if the tumor is in the retromolar trigone? If the tumor is in the retromolar trigone, again, you will go for a CT scan with contrast, plus minus ultrasonography of the neck. I always do for my patients. Ultrasonography has a different modality, but if you want the same thing, see, whenever you're talking about oral cancers, you have to think about two things: the primary site where the tumor is, and the secondary site where metastasis is expected. So all oral cancers do metastasize to the neck, to the different levels. So there has to be a treatment or a imaging modality for the neck. There has to be an imaging modality for the primary site. So this is how it goes. Chirag, next slide, please. Okay, so when we're talking about all these cancers, we spoke about little clinic. We have to go a little bit in theory and try to understand, what it is all about. So just remember, Chirag, you have to, one second, I'm sorry. One second. Okay, so what is it? When you talk about neoplasia, what is it? Basically means a new growth, a growth which was not there and now it's there. So by definition, an old definition, it just means an abnormal mass or a new growth which was not present there and now is there. Next slide. Chirag, you have to give me the control. I think that's better. Okay. So whenever you're talking about cancers, you have two components. You have an epithelial component and you have a parenchymal component, or the connective tissue component. If the cancer is in the epithelia, it can be a squamous cell carcinoma in situ, or it can be a very superficial T1 lesion. But if the cancer is deeper, it is gone into the submucosal level, then obviously it upgrades itself and gets classified as probably a T2 or a T3 tumor, depending upon the depth, probably what we see on an MRI or a CT, and ultimately has to be treated in a different way. So all tumors have two components, unless it's a very, very superficial tumor, it's just in the epithelium, probably a carcinoma in C2 or just a very early T1 lesion. All right. So we have to think about both the tumors. So this is a terminology. I'll not go into this. So whenever your oral pathologist or a general pathologist talks about cancer, he's looking at these things. Pleomorphism, nucleocytoplasmic ratio, the ratio of the nucleus and the cytoplasm. So you see hyperchromatism, basically. You see a lot of hyperchromatic granules, nucleuses. You see abnormal mitotic figures, and on this basis, he will give you a diagnosis. Now, what is this? Doctor, I have got a patient who has a well-differentiated carcinoma, and who has a moderately differentiated carcinoma, and who has a poorly differentiated. What does all this mean? See, basically, it tells you about the prognosis of the patient on a long term. They will all be treated mostly, especially the well-differentiated and moderately, most of the times, almost the same way. But poorly differentiated tumors increase the risk of metastasis, increase the risk of long-term survival rates, they reduce it, and also should be treated more aggressively. So when you have a biopsy saying it's a moderately differentiated or especially poorly differentiated, you know that this patient will require a more aggressive therapy. Now I get this, again, I get calls, I have small nodule patient having a nodule in the mouth, it is benign or malignant. It's very simple. Just go on these points. Just see whether it's well circumscribed, just see the size, just see the duration, and look at the peduncle. Usually the pedunculated masses, which are freely mobile, there is no pain associated, they are benign. On the other hand, if you have something which is indurated, which is thick, which is looking red or reddish white, which has suddenly grown in size, which has caused some kind of numbness, think malignant about it. All right. So this is a small thing. I just wanted to show you the load of, just have a look. See the lip and the oral cavity. This is the index from a government source. So we have around 1 lakh plus cases, around 1,20,000 cases in India alone. I mean, I'm not talking about Asia. So 1,20,000 cases alone in the country is a very big number. I'm just talking about oral cancers, oral and lip. I'm not talking about head and neck. Probably they're more than 30%. So these oral cancer, 1 lakh patients, I don't think so. We are treating even 1/3 of them. We might be treating probably 20% or 30. So what's happening to the rest? God knows. Because these patients don't reach us. They are whatever referred to places which are very, very busy already, or they have no time or whatever, and they have this self-belief that if we go there, we'll get cured. It's not like that. You have to reach a person who can cure you. You have to reach a person who can take this cancer out safely without causing more harm, who's trained to do it. Now, secondly, what is the distribution of oral cancers in India? So you will be surprised that, most of us are right-handed. So the left buccal mucosa is the most common site. So mostly in India, we get gingivobuccal sulcus or the buccal mucosa left side, or an RMT or tongue. Floor of mouth and all is quite rare. What is the overall size? See, all this is very, very important. This is not what I am saying. These are all meta-centric, multi-centric trials which were conducted. And this is what the truth is. So even if it's a localized cancer, you have a very good 59 to 60% survival rate after 5 years. Now, if it's a localized cancer which has gone to the neck, then the survival rate reduces. So before it goes to the neck, you're supposed to help these patients. You have to do all the things needed, which I have told you, and refer them ASAP. I'll not go into all this. This is all too much. In my practice, probably, in past 8-9 years, most of my patients who have come to me primarily or secondary were having the history of tobacco chewing. So any kind of gutka, pan, mishri, whatever, XYZ things, these things remain in contact with the mucosa. And ultimately, they become carcinogenic, and ultimately these result in formation of ulcer. For that matter, many of the people who chew them, you will be shocked to know, they sleep in the night, by keeping them in the vestibule or whatever. So keeping the thing in the vestibule is a very, very risky thing. And ultimately, they do land up with cancer. Is nicotine responsible for cancer? No. So what is responsible for cancer? Cancer is caused by 30 components which are present in tobacco. Few I'll just name: nitrosamines, polycyclic aromatic hydrocarbons, and there are many like these, So these are the things which will cause cancer. Nicotine itself, no, because otherwise, when we keep patients on cessation, we prescribe them nicotine lozenges and chewing gum, they themselves might have caused cancer. So it is basically the aromatic compound groups and the nitrosamines and the benzyl amines and all those things, roughly around 28, 30, which are responsible for causing cancer. So these are the different types of cancers. Cigarette smoking, uh, oral cancer, less, but definitely have a role in oropharyngeal, laryngeal, and lung cancers. Same with BD. I'll just go through this fast. This is very bad. This pan masala and mawa and all this, they are chewable, smokeless tobaccos, kheni, mishri. Okay, this is one thing which again wherever I go to attend a party or whatever, they start asking me all this and they are doing, unfortunately they're doing at the same time. So smoking and drinking, it's a very, very, you can say, dangerous cocktail. See what's happening when you take alcohol, basically, you're reducing the formation of saliva, number one, which is a protective mechanism. You are increasing the epithelial permeability of your oral mucous membrane. You're allowing the carcinogenic compounds present in the cigarette smoke to go in a deeper layer because your mucosa is permeable now. And on the contrary, if you're chronic alcoholic, you're already probably you're deficit by nutrition, your liver is kind of screwed, So all these things together will put you in a kind of a high risk. So ideally, you should not do both the things together, or for that matter, none. All right. So viruses, just remember one thing: for oral cancers, HPV. That's all. Rest all Epstein-Barr in India and all that is not very common. HPV 16 and 18. If you want to send the patient sample for PCR and all that, they will tell you subside. But usually, oropharyngeal cancers are caused by human papilloma virus. If an oral cancer is caused by human papilloma virus, it's a good news because these patients will do much better on a long-term basis than patients who have a history of consuming tobacco. Diet and nutrition, we all know about this. I'll just go for a small, table, and then probably we can take it from there. So what is happening? How does the cancer form? There's a big question. Oh my God, so much literature and all those things. See, a normal cell is continuously irritated. There's a damage to the DNA. There is mutation of the genes. And ultimately, once your cellular genes get mutated, there is activation of growth or the growth promoting oncogenes. Okay. And there is a suppression of some cancer preventing oncogenes. So what is happening? Actually, the balance is getting diverted in favor of formation of a cancer. So there's an expression of the altered gene products, and ultimately which results in an uncontrolled growth and ultimately a tumor. So every cancer goes through two phases. There is promotion, basically the irritation and all that, and ultimately progression in size. All right, so I'll just remember, this is very important: P16 activation and 3P deletion. So P16 activation is a very important thing in formation of oral cancer. So what happens? See, is normal mucosa, squamous hyperplasia, ultimately developing dysplasia. So if, for example, you have a patient who had a non-healing ulcer or whatever, and you thought it's a cancer, you did a biopsy, it's dysplasia. What should you do? If you have a patient who had a red and white lesion, it comes out as dysplasia. Technically, you're supposed to operate this patient. Now here it comes, whether you can operate with the laser or not, whether you should use a cautery or not, whether you should. These are the early patients. Okay, lasers in oral cancers are only used for pre-malignant carcinoma in situ type of conditions. Laser is not some god's magic wand. Don't think that laser itself is something like induced radiotherapy or chemotherapy. So these lasers is basically just a kind of a pencil which kind of cuts tissue. Okay, but to a certain depth, 2 millimeter or 4, depending upon what laser you're using. So laser because their depth is controlled, for superficial things, you can use it, all right? Probably for leukoplakia, and I'll tell you when to exercise and what type to exercise. But for deep tumors, for proper T1, T2, you don't do all this, okay? This is rubbish. You have to use a cautery, you have to do it properly, you have to take 1 centimeter of margin in all dimensions, including the base, all right? Okay, so this is fine. I'll just, okay, this is important for you, you know. How does a cancer spread? So, okay, so there is a local spread, there is spread through the nerves, there is spread through the vessels, there is direct spread through the spaces or the cavities. And how does it spread basically, you know? It can spread in a center, it can have pushing fronts, or it can spread in any of the other directions, you know, that's okay. So what happens in the oral cavity? See, oral cavity follows the same principles, or the cancers of the oral cavity follow the same principles as cancer of, probably as an infection. All right, so it will go to the path of least resistance. Fair enough. So what is that path of least resistance? Okay, so least resistance means, for example, you have a growth in the retromolar trigone, all right? So laterally from the, I'll show you by pictures, laterally its tumor is more likely to go laterally because there's nothing lateral, there's just buccinator. So if it is posterior to the attachment of buccinator, there's nothing to prevent it to go to the buccal space. So this tumor in the retromolar will go laterally to the buccal space. Now, if this tumor hasn't got any obstruction to go medially, and the medial pterygoid is attached little posteriorly, it will go to the masticatory space. It will just go between the medial pterygoid and the ramus of the mandible. So it starts involving, the patient develops trismus. Okay, just forgot to tell you in the history, trismus, do ask for trismus. And in trismus, what is important is the duration of trismus. Trismus has, don't get excited. The thing is for how long. If it's a trismus which has just started and there is an ulcer in the RMT, or there is an ulcer very close to the masticatory spaces, probably a posterior GB sulcus, that should ring bells. And you should understand this is a short duration trismus. So it cannot be something like submucosal fibrosis or something benign. If patient says, my mouth is not opening since a long time, probably for years, it's a good news. Long duration trismus, good news. Short duration trismus, scary news. Fair enough. Coming back to the spread of these tumors, from tongue, for example, you have a tongue cancer, there's no obstruction between tongue and the floor of mouth, technically, except for the genial muscles. All right. So once this border of genial muscles is crossed, when you're talking about downward spread, it can directly go to the sublingual space. Now, if sublingual space gets involved, your mylohyoid will get involved. If mylohyoid gets involved, you know, your skin outside the mylohyoid will get involved. So, you know, it's simple. It's basically the path of least resistance. And obviously there are rich lymphatics which connect the oral cavity to the neck. So this is the region, this is the reason that patients having oral cancers have neck nodes, because these cancer cells are going to get deposited in the lymphatic system, and from the lymphatic system, they're going to go into the lymphatic system of the neck. That's why you do the neck dissection for them. Hematogenous spread, very interesting. Just see, mostly we see it in sarcomas or the connective tissue tumors. Oral cancers, we do see them, but if it's not a good news, because if there is a lymphovascular invasion, or you know the tumor cells have already gone, there are high chances that these patients will develop long distance metastasis, either to the lungs or to the liver or to the bones or to the spine. So when you send your sample after surgery, which is called as the histopathology report, so something called as biopsy is the initial thing, and then something called as HPR, the histopathology report. So when you send this sample for the histopathology report, there is something known as LVI, lymphovascular invasion, which a histopathologist will tell you. So if the patient has LVI, that patient comes in the high risk, and as he's coming in high risk, it's very important to treat that patient with adjuvant therapy, okay, for the primary site. All right, I'll talk about it later. So just a diagram to show how it happens. You can click pictures, no problem. All right, so from the, see from there, it comes to the base, these cells come to the basement membrane, and actually they cause damage to the endothelial cells, and from the main blood get attached. They have to get attached to something, so either RBCs or the platelets, and once they get attached to something into the vascular system, they can go anywhere. That's the reason why an oral cancer will have a lung met. That's the reason why an oral cancer will have a spinal met. Okay, so don't be shocked next time. So this is the, this is the way. Oral cancers, in short, I'll tell you what happens in oral cancer. How does the mandible gets involved? So if you have a buccal mucosa tumor, so along the buccal mucosa, it will go up and it will enter the alveolar. See, it's very difficult for these tumors to enter directly because mandible is strong. So even if you have a gingivobuccal sulcus tumor, very rare, unless it's a very big and a long-standing and aggressive tumor, it will not cause erosion of the lateral cortex. It's strong. So what does it do? It climbs up and tries to go to the periodontal region or the medullary bone. So it goes from up. It goes up. It's a buccal mucosa, becomes gingivobuccal sulcus, and ultimately it dips into the alveolus. This is how it happens. These are some pictures which tells you that. So same, if it's a maxilla, it can involve maxillary sinus. From the maxillary sinus, if it goes superiorly, it will involve the orbit. If it goes posteriorly or the posteromedially, it will cause involvement of the infratemporal fossa. If it goes medially, it will involve the nose and the lateral wall of the nose. So it's very important to understand the origin of the tumor, right? So sometimes you feel, the origin is different and the extent is different. So you have to understand, look at the scans, come to a conclusion that actually where is the center of this tumor from which it has originated. All right, so this is the most common way it happens, all right? So alveolar mucosa, so a lower alveolus, so within the alveolus, then it involves the medullary spaces, where once it enters the medulla, it will involve the nerve or the neurovascular bundle, and ultimately it can go distally, that is away from the midline, and or go proximally. Proximally along the nerve, so nerve, if you remember, V2, from where does it come out? You should know that. Ultimately, it can involve the infratemporal fossa, so RMT tumor, which has entered the bone, can cause a perineural invasion, and ultimately perineural invasion can take the tumor cells along at a higher level to involve the base of the skull. Okay, so this is how it happens. Okay, this is just, it's a very important thing, the pre-malignant lesions. So this is a good paper which recently came out. So pre-malignant lesions, basically, what in very precise way I'll tell you. Okay, so this is what the disorders were classified in 2017. Remember, leukoplakia, erythroplakia, mixed leukoerythroplakia, submucosal fibrosis, smoker's palate, lupus, oral lichen planus, and cheilitis. Now, what is this leukoplakia? Which leukoplakia is dangerous? When should I take a biopsy? From where should I and when should we excise? Nodular leukoplakia which has increased in size, is thick. I'm sorry, some idiot, So leukoplakia which is thickened leukoplakia, you feel on palpation is nodular, and you feel, it is becoming painful, which it was not. This is the leukoplakia, which is a scary leukoplakia. You might have to excise this or take a biopsy. How to take a biopsy? For leukoplakia, usually you do an excisional biopsy, all right? So you clear with a nice cautery or a laser or whatever you want with good 1 centimeter or minimum 5 millimeter margins. Erythroplakia, there are a lot of papers which tell us that erythroplakia, for that matter, 40 to 60% of these tumors do have squamous cell carcinoma in situ when they come to you. So these patients, you have to be very careful, keep on looking at them, call them after 2 months or 6 weeks, especially 5 to 6 weeks, and just see if there are any changes that are occurring. And whenever you feel suddenly it has increased in size or suddenly it's causing burning sensation, this is the time when you will go in and take a biopsy. Excisional biopsy mostly, or you will plan for a proper surgery. Mixed lesions. Now I have people call and just ask, doctor, I have a red-white lesion. What should I do? From where to take a biopsy? It's very simple. Don't take a biopsy from a white side. It's going to be benign. Always in a mixed lesion, take a biopsy from a red side, because red side is a sinister site. This is the site which is going to cause problems. All right. Submucosal fibrosis, very rare it will go into formation of oral cancer. Unless you develop something within the submucosal fibrosis which is ulcerative, do not bother much. These have to be treated by surgery, especially stage 3, stage 4 oral submucosal fibrosis. Khanna and Andrade 1992 article which talks about different modalities and the staging system of submucosal fibrosis. So what are the best ways to treat? Please understand, unless it's stage 1 and 2, your all injections, steroids and all hyaluronides, all that blah blah is okay. It might help or it might not help, and nobody knows, everybody's happy. But once it is reduced mouth opening and the fibrous bands have already formed and developed, do not keep on injecting them unnecessarily. They need a nasolabial flap. They need surgery. Whoever tells you anything, it will not work. Once the level, once it goes to stage 3, 4, or whatever, 4A, 4B, he classified into different types. Uh, that time, no form of conservative management is going to help these patients. So you have to take them for surgery. Now, this is something different. So they have found out, now this after 2017, these 4 have been added, you know. So hyperplastic candidosis, lichenoid reactions, so all of them have roughly 2% chances of having squamous cell carcinoma over a period of 10 to 15 years. Just keep them under observation. Look for any kind of change in the symptoms the patient is telling you. Suddenly the patient says, I was not feeling burning, now I'm feeling burning. Since suddenly the pain is there, or suddenly the lesion is looking more fiery red and it was not looking. That is the time when you'll go in and do a biopsy or some kind of excision. All right. So these are some kind of red and white lesions and some cancers. Okay, so this is a leukoplakia. All right, again, this is a squamous cell carcinoma. This is typical thing when you have a cheek bite, you know, to see this ulcerated lesion. And I mean, I'm telling you frankly, a lot of patients come to me because, you know, doctors are giving them multivitamins and all blah, blah. This is not going to help. I mean, this is a proper ulcerated lesion in the retromolar trigone. It needs a biopsy. It is not going to heal very soon unless at an early stage and you have removed the irritating factor. That is the last tooth probably. It's not going to heal. Okay, it's a fully developed lesion now. You have to go in and take a punch biopsy or an eye biopsy. These are the symptoms. Okay, so you have to be careful about them. These are the subsites. All right, different subsites. Okay, just have a look. People who have not seen many cancers, just have a look. Cancers always look like this. These are more of exophytic pictures, what I'm showing you. Sometimes they are also infiltrative. So, you know, there is a submucosal part which is more predominant for these lesions. All right. So how do you detect them? You know, the question sometimes asked, should I do toluidine blue staining? What is well scope? What is immunofluorescence? Please understand one thing. The best thing to diagnose any kind of oral lesion is a biopsy. There's nothing better than that. Next thing, if you don't have a knife, if you live in a forest and, you know, you have no knife or you do not have a punch forceps, the next option which is closest is probably a fluoroscope. All right. So, but there is not, till date, there is no convincing evidence that fluoroscope or toluidine blue is better than anything. Very primitive camps which are conducted on mountains and, you know, probably deep forests and in areas where instrumentation is not possible. Exfoliative cytology is the next best thing. You can just use a brush border thing. With a brush, you can just push the brush in the lesion and you will get some cells, and you can you know, send these cells to the pathologist and he can or she can tell you what it is. Radiographs we have already discussed. FNAC I want to talk about a little bit and then probably I'll end it. FNAC, please remember one thing. When do you do an FNAC? You have a patient who has nothing in the oral cavity. So you have a node, okay, enlarged node. You put the patient, enlarged node can be due to inflammation, can be due to benign, can be a malignant, okay, or can be and something known as immunosuppressive or whatever. So these patients, you should know why the node has enlarged. All right. So you keep the patient on antibiotics, you keep the patient on analgesics, and basically you wait and watch for the node to settle down. Now this node doesn't settle down. Okay, it just increases more in size. Fair enough. So what to do? So first thing you will do for an enlarged node is an ultrasonography. So when you write an ultrasonography, please remember that mention, map the lymph nodes. Do not write USG and you think you know everything. USG, he will just tell you, okay, thyroid gland is normal, lymph nodes are normal. He will not tell you. The ultrasonologist will not tell you what, he will not understand what do you mean. So what he's going to tell you, carotid is present, vein, internal jugular vein is present, nodes are there. Obviously, everybody has lymph nodes, and nothing clinically significant comes out of it. So what is the thing you have to mention? Whenever you want a neck mapping, you have to write, kindly do the mapping of lymph nodes on both the sides. All right, both the sides. So when you map it, it comes as reactive, it comes as intermediate, it comes as suspicious, it comes as malignant. So for example, this patient, you suspect something in the oral cavity, okay, there is a lesion and he has an enlarged node, and you have not done a biopsy, and probably you want to know the because you rather do biopsy and have a primary diagnosis. Or the other way around, you just have a node which is not resolving. So what you will do, the next step after ultrasonography is USG guided FNAC. FNAC. The problem with FNAC is it has got a lot of percentage of false negative and false positive. So it has a lot of errors. So it depends on an individual who is doing it. So ultrasonography, still you don't know. There's nothing in the oral cavity. There's nothing. I mean, it's inconclusive, your result of FNAC. The patient is on your head. Patient wants, doctor, what is happening? Start treatment. It is just growing. You will go in and do an excisional lymph node biopsy. You will open the neck. You will talk to your surgeon. He will go in and take a part of that node. All right, this will give a definitive. Still there is nothing. Send it for IHC. It will definitely give you a result. All right. So tumor markers, IHC is something higher than a biopsy. Biopsy is not helping you. Slide review. You have changed the pathologist. You can go for all these things. Okay, grading. So this is the 8th edition classification, which you should all know now. Forget what you knew before. So just see this. They have included this depth, 5 millimeter depth now. So everything is about this depth now, 5 millimeter, less than 5 millimeter, 5 to 10 millimeter, less than 10 millimeter, or whatever. So this is what is followed all over the world now. It is no more the kind of a Mughal Empire classification what we had before. So this has changed last year. So you have to follow this. And with respect to neck nodes, also they have added this extra nodal extension. So what is extra nodal extension? If you have a lymph node and it's a diseased lymph node, and the disease has gone into the capsule, and from the capsule it has come out, and it has caused the lymph nodes restricted mobility. So it becomes a extranodal extension of the disease. The disease has come outside the node. Okay, all this will help you in planning your treatment, because patients who will have an extranodal extension on histopathological resection report, not pre-surgery, okay, even if pre-surgery, they will require, and most of the times, adjuvant therapy, either with chemo or radiation. So what is the primary strategy for prevention? Pick up these patients faster, do an early biopsy, refer them nicely. You tell these patients, usually patients with so-called red and white lesions, they should be very careful whenever they brush. They should see properly the size, whether it's increasing or reducing, because you can save a life. Trust me, you can save a life, you can save a family, you can save many people related to those people. What are the management modalities? You have surgery for the primary and the neck. You do a resection or a alveolar, what you call it, marginal mandibulectomy, or a resection. You can do laser. Laser is only for red and white and all this leukoplakia. We do not do laser for cancer. If you have a proper squamous cell carcinoma, laser is not indicated, because I want 5 millimeter, I want 1 centimeter depth. Lasers usually cut only till 2 to 4 millimeters. So it will be a failed surgery. So surgeon success in oral oncology is primarily with the margins which we get with the reports. All right. So radiation. When do you give radiation, doctor? Radiation or chemo is decided on histopathology report. All right. So if the patient is a high risk, it was a poorly differentiated carcinoma, it is a T2 tumor or T3 tumor with perineural invasion, with lymphovascular invasion, poorly differentiated, and probably and probably 1 or 2 nodes were positive. Once you remove these nodes and you send for histopathology, these are the patients which will require radiotherapy. Now, doctor, which patients require chemotherapy? Now, same scenario, T3, T4 lesions, which have a depth more than 5 millimeters, 5 to 9 or more than. See, it is different again for different sub areas. So for tongue, say for example 9 millimeter or more than 5 millimeter, it's risky because it has more lymphatics. All right, so a lot of chances that it will metastasize. Or a patient has a lymphovascular invasion in any subsite, buccal mucosa, tongue, or alveolus or palate, and patient had, and you have a positive margin, means whatever you have removed only less than 1 centimeter or even less than 5 millimeter. So less than 5 millimeter is positive, till 5 millimeter it's kind of adequate. There are different theories to that, but we usually keep 1 centimeter on being on a safer side. So if your margin is positive, this is one very good indication to give chemotherapy along with radiation. So this becomes your adjuvant therapy. All right. So in general, T1, T2 tumors are treated with surgery and reconstruction. Dr. Shakti Singh is a very good reconstructive surgeon. He will tell you all about. So these are indications. Please take a picture or whatever, you remember this. So positive margins, locally advanced T3, T4, high-grade perineural invasion, all this will be a part of a histopathology report which comes after surgery. So after understanding all this, you will send the patient for adjuvant therapy. So whether you give him radiation or chemo, it depends on the histopath report. Brachytherapy and all is outdated. Nobody usually does it. It's done at some centers. I just want to talk for 2 minutes on chemotherapy. There are different types of chemotherapy. We are sometimes called and asked, okay, he's taking neoadjuvant chemotherapy. What is neoadjuvant? So in oral cancers, very few indications are there for neoadjuvant chemotherapy. All right, what are these indications? Tumors which you feel are are borderline tumors, where you feel you cannot give a 1 centimeter margin and will be difficult to resect. These are the tumors which will require probably 2 to 3 cycles of chemotherapy. Probably it will reduce the tumor load, and then you resect according to the previous dimensions of the tumor, and it helps because it kinds of makes the field sterile. So there are very few indications for neoadjuvant chemotherapy in head and neck cancers. I mean, there are hardly any papers on it, but whatever papers are there, it is only for borderline cases. All right, so adjuvant is after surgery along with radiotherapy. So you add chemotherapy, it improves the overall prognosis of the patient on a long run. So neoadjuvant is the before starting a permanent therapy, which might be surgery or radiation, you give something upfront that becomes a neoadjuvant. So neoadjuvant is what you start before a definitive treatment plan. So it can be 2 cycles, 3 cycles to reduce the tumor, and then do surgery, and after surgery do radio and chemo again. So the final things, I just want to take 2 minutes, probably last. So whom to refer and when to refer, very important. See, as soon as you have a biopsy report, talk to a person whom you feel is good enough to do the things, and just talk to him on the phone and take his help or her help and just follow up with him. So again, very important. Okay, don't refer your patients to people who are part-time surgeons or whatever. You should be totally involved with oncology full-time, day in, day out, to give the best results. Help patients who want to get operated. See, in Bombay, we get a lot of patients from Ahmedabad, Surat. They just somehow want to come here. Help them. Find out who's best there. Talk to that person on the phone. Take his appointment for verbal communication. He might be somebody who knows somebody. So help them to fix the appointments, follow up with them, and try to come. Obviously not outside the state, but if you're taking him to a local surgeon, go with the patient for the first time. It helps the patient. It gives them motivation to take the treatment. All right. So I'll just stop. I think these are my attachments. I work with like something like 10, 15 hospitals all over Bombay and Navi Mumbai. Okay. So you're most welcome anytime to, if I can help you verbally or whatever way, you can just call me up. And these are some patients. I mean, I don't know, like just to show you some anatomy. You can see this is the sternocleidomastoid, this is the posterior belly. So we are seeing from the right side of the neck, anterior belly digastric, posterior belly. This is the mylohyoid muscle. Okay, this is the sternocleidomastoid. This is the common facial vein. This is the internal jugular vein. You can see in the shadow superior thyroid artery. This is the thyroid gland. All right, so this is the level of 1A. This is 1B. This is 2A, 2B, 3, 4, and probably 5. All right, so these are some patients, very interesting cases. We did a very big case last week. It was a huge neurofibroma. I was discussing with Shakti also. It's a very massive thing. We just removed his whatever possible, and this is the specimen, and he's doing quite well now. So this is he's not the same one. This is the one after surgery. Now this guy basically, is a person who has undergone surgery, reconstruction, and is on a follow-up. I could have kept at least 300 more pictures, but I didn't get time. So these patients, now people call me and say whether surgery ke baad he can have a normal life. Look at him here. I mean, he looks normal than most of us. So it is a wrong belief that these patients will never be normal and all. It depends. It depends how much we all can work towards the normalcy of that patient in the future. It's difficult to cope up. It's difficult to basically, engulf everything, but we are always available, and you can just anytime send a message across. My number is there. You can take it from Chirag or whatever. and you can call me and take a opinion or a helping, just to help someone. All right. So what is the takeaway message? Last slide. Do biopsy. If you have a doubt on any lesion not healing more than 3 weeks, please go in and take a biopsy. Get the right image going. Now you know your denta scan and bloody all this OPG is all bullshit. It does not work for tumors. You have to know the soft tissue. Even if it's a primary, see, OPG needs 20 to 30% resorption of minerals till it's seen on the OPG. So if it's a subtle resorption, you will never come to know if it's there. So it's a wrong investigation of choice. Keep involved in the case. Cancer case is not just like these are the cases where the patient will die if you're not serious about it. So you have to give maximum attention to these patients. Okay, so this is my personal thing. Many doctors have degrees which cannot be bought, but skills cannot. So skill, having a qualification, FRCS, MCS, blah blah blah, it's another thing. But are you the one who can do the job to the extent of a good level? That's very important. So you have to train well. You have to operate these cases. We do it every day almost. I almost do it every day. So it's a very, very important thing. Then only your hands settle, then only your mind and eyes settle. So this is how it is. Okay. So I think Chirag, you can tell Dr. Shakti to start. Thank you very much.
Yeah, Dr. Shakti, if you can just, hi sir.
Yeah,
so
hi.
Before we start with the next session, will it be okay if we just take a 5-minute question answer session?
Yeah, break. Even I am getting addicted.
Yeah, so 5-minute question answer kar lete, so everybody will have a break. Is that okay?
Yeah, okay.
Yeah. Sir, Shakti sir, you also please give your inputs on the questions. So we have around 15-16 questions which have come up. I'll just ask a few of them because most of them are related to each other.
Okay.
So one is, why do HPV positive patients have a better response to treatment as compared to an HPV negative or a tobacco induced cancer?
So they have a low incidence of aneuploidy. Aneuploidy is basically the type of DNA damage that occurs, all right? So they have found that over a long period of time, these patients, for example, if the survival rate is say 60% for a patient who has a history of tobacco chewing for oral cancer and a patient who has no history, they have found that it's almost as good as 80% to 78%, 78% in patients having HPV. So HPV 16 and 18 is the one responsible for oropharyngeal cancers. And these patients scientifically have been found to do well because of the less of DNA damage, and the repair mechanism after DNA damage by the body itself has been found to be better. So that's why they do better. All right.
Then the next question is, if the lesion is less than 0.5 centimeters, would you still go in and do an incisional biopsy or what?
It is not about the lesion. It's about how the lesion, it's not about the size. See, you can have a big fibroma hanging outside your mouth. But that's a fibroma. It's a pedunculated benign mass, like this. So be very sure that it's benign. My only concern is I see people, just trying to do some kind of surgery. There's no some kind of surgery. You have to be sure this is a mucocele. I'm excising. It's not cancer. It's fine. You can do it. You don't need any margin for that. But when you have a reddish white lesion, you need at least 5 millimeter to 1 centimeter margin. So it depends on depends on the appearance of the lesion. It's not about the size, it's the appearance. Next.
Okay. So does biopsy also see tumor cells?
Biopsy only sees tumor cells. So you just see the normal tissue.
The seeding of tissue cells.
So you see the normal tissue, and in the normal tissue, you see cells with those 5 things which I have told. Hyperchromatism, increased nuclear to cytoplasmic ratio, increased mitotic activity, and reduced size of the nucleus. So all these things will go in favor of a malignancy.
Okay. So then the next question would be, so what is compartmental resection and what is tumor lateralization?
So lateralization is which side the tumor is. Is it right lateral or left lateral? It's just the side. Compartmental clearance is when you basically clear the whole compartment in which the tumor. It has not. There are a lot of papers on the compartment clearance, especially for the tongue cancers, but none of them have actually found that the over a period of time or the long-term prognosis is better for these patients. So what is basically tongue compartment clearance or any compartment clearance? You move everything in that area. All the muscles right from origin to insertion. So for example, if it's a T1 tumor in the tongue, you will not remove stylohyoid, mylohyoid, geniohyoid, you will make a big defect. Or a T2 tumor. See, sometimes you can be a little conservative. Once you have achieved your 1 centimeter margin, it's good enough. So compartment clearance concept was brought in by, if I'm not wrong, I think by Koreans, and then by, I think, by Europeans, and followed by Americans. So, but it has not shown over a period of long time, the survival rates have not improved. So that's why it is not a procedure that is done quite often. You just restrict yourself to 1 centimeter margin. If you're practicing any kind of surgery for a lesion which is malignant, make sure you have 1 centimeter all around, and especially at the depth of the tumor. That's very important.
So, sir, one is for pre-malignant lesions, do you excise them always, or what?
So lesions, leukoplakia, homogeneous, no need of excision, just observe the patient. Non-homogeneous, nodular leukoplakia, excise, laser, cautery, your choice, knife, your choice. Erythroleukoplakia, look at them, see the size, call them after 6 weeks again, call them 6. If you feel they're increasing, you're having pain suddenly which was not there, they're looking more reddish, more inflammatory, burning sensation, and go ahead and do a biopsy or do an excisional biopsy. Most of the times, you will find these patients have carcinoma in situ. You do not need to do a neck dissection for this patient. It just needs a plus 5 millimeter clearance, especially, to clear the issue. And the patient is usually safe after that. Okay.
Okay. So, sir, next is if we don't have an MRI neck or a PET CT in a tongue squamous cell carcinoma, okay, till what level should we do the neck dissection?
So PET CT, okay, let's be very clear. We do not do PET CT for T1, T2 tumors. We do PET CT for T3, T4 tumors, especially for T4 tumors when you expect these tumors, especially in very dangerous areas. See, the tongue and floor of mouth is very, very considered sinister. So when a T4 tumor is in the tongue or it's in the floor of mouth, there's a high chance that these tumors will metastasize. And because these tumors have high chances of metastasis, you want to make sure that they have not metastasized to the lungs, to the spine, to anywhere, to the wherever possible. Because if that's happened, you cannot treat these patients. You have to treat them with palliative care. That is palliative CT or whatever, palliative CT-RT or whatever way. There are different types of palliative treatment plans for these patients. But if you operate these patients and this patient comes within a month, then patients can always ask you, why didn't you do a PET scan? So nowadays, like still it's in the process, many patients who are having T4 tumors of the tongue especially and floor of mouth, it's better to do a PET scan to rule out distant metastasis.
Okay. So do you do biopsy before imaging or after imaging?
Oh, good question. See, what happens after imaging, before imaging is mostly we should do it, but it's better to do after imaging. Why? Because imaging, if there is always inflammatory response that occurs after doing a biopsy. So it might, in some cases, upgrade the tumor. So T1, because of edema, because of all that sets in after biopsy, might look as T2. All right. So it's better to do the imaging first and then the biopsy, technically, if you ask me. Yeah.
Then one would be, so frozen section is mandatory?
We hardly have in most of the hospitals, So we usually keep 1 centimeter. We make sure it is 1 centimeter. Frozen section is a privilege in only tertiary care hospitals. But usually we do 70 to 60% of our surgeries, 50% at least without frozen section. But 98% of the times we are quite safe, So you get into a habit. If it's there, very good. You can call somebody having a frozen section machine. It will just charge you extra, and you can pay that patient. So it can be made available, depends on the budget of the patient and all those things.
Okay. So there are a few more questions, but I think let's take it after the session.
Chirag, you can ask me probably one and then Shakti can start. Important if something you find it.
Okay. So I think one which I really like was that which node should be considered in TNM classification? Like when we are classifying, which node should be taken? Whether it should be tender, non-tender, fixed, mobile, or are there any specific characterization of node which needs to be included in TNM classification?
So any node which is enlarged for more than around 1 centimeter. So usually the nodes are around 5-6 millimeters. So anything which is close to 1 centimeter should raise alarm bells. Node which is around 1 centimeter, more round than oval. Nodes are oval, they are oval. So if it becomes more round, it is known as a rounding index. It becomes more round, that means the oval part is gone, and there's some kind of thing that is occurring here which has caused to change. It has changed the shape. It has become more roundish, or it has become little hard. So, or it is not responding to your clinical administration of antibiotics and anti-inflammatories. These are the nodes you will investigate further. All right, fixed node means patient is as good as in the palliative care. Fixed node is a very, very bad prognosis. It only happens in cancers. Rubbery nodes, mostly lymphomas or tuberculosis. These are very common, or some kind of a connective tissue disorder, infectious mononucleosis, Hashimoto's disease, and we can go on and on. But commonly seen things are tuberculosis. Is when talking about neck nodes, benign tuberculosis, inflammatory tuberculosis. They have caseous necrosis, and benign lymphomas, very, very common. You have multiple nodes in the neck, bilateral in distribution. So whether it's unilateral or bilateral, some patients have multiple nodes, but they do not have anything in the oral cavity. So mostly that diagnosis goes in favor of clinical, if you ask me, a lymphoma or tuberculosis. In that case, I will do an FNAC. If FNAC tells me what it is, it's fine. Otherwise, I'll go an excisional biopsy.
Okay. So we'll ask few questions later now.
Yeah. Please tell Dr. Shakti to start.
Now,
just two comments from my side. Deepak, it was a great, very informative, very detailed presentation. I think it is going to be very helpful to the people who are here today with us. So I want to make two comments. One on biopsy, as you said. So there are many people who think it's a small lesion, we should excise it. So as Deepak said, if you are suspicious, even 1%, do not excise or do not do the excision biopsy. The moment you do the excision biopsy, you are violating the planes of resection, and later it becomes very difficult for the operating surgeon to redo the surgery. So it is very, very difficult situations, and we are facing these situations many a times. People are just doing small excision, small ulcer, they will just do the excision. There is nothing called a small cancer and big cancer. Cancer is cancer. It has to be treated with the proper oncology care. Second important comment is what we are seeing in common practice, that many patients came to us post extraction. Now we know there is something wrong in the probably the gums, or you can say in the alveolus part, but still people are doing extraction without seeing it. There is a problem lies down. Now these patients came to us and they said, "Saab, daant nikala, usse cancer ho gaya." Now this is the thing which we were hearing since last, when we were students 15 years back. And same thing we are experiencing today in our setup, that people are coming to us and saying it, ki saab daant nikala aur cancer ho gaya. So somewhere I think we need to train our people. They need to be very, very cautious, because what is happening is, it's a very important thing what my boss has said once. Any tooth in oral cavity which is mobile and rest all teeth are intact, do not remove the tooth without adequate imaging. Be it if the tooth is mobile, if you are available with IOPA, just do an IOPA, preferably do an OPG, but do not extract the tooth just because patient is saying कि साहब ये तो दांत निकाल दो मुझे दुख रहा है. You will end up in trouble. And in this period of lockdown, we have experienced 4 patients. I tell you, I personally have experienced last month 4 patients who came with post extraction, and the moment you extract the tooth, the disease usually progresses because it gets into the marrow and it spreads to the marrow. So its aggressiveness increases. So very important, 2 more messages I would like to give. Do not excise the tumor whenever you're suspicious or do excision biopsy. Second, do not extract any tooth when there is something wrong or when the tooth is mobile and all teeth are intact. So these two important points, Deepak, I wanted to comment, and I think it is
Perfect. You have really hit the nail, you know. Yeah. So
Sir, if you can just start screen sharing.
okay. So let us start our presentation. 1 minute. Share.
Yeah, I can see it now, sir.
Okay.
it's a very Gujarati presentation. Nice colors. I can.
1 minute.
Yeah.
Okay. Is it visible now, Chirag?
Yes, sir. It is. It is okay. You can start. Thank you.
Okay. So first of all, I would like to thank Chirag, Parth, and Dr. Deepak for giving us this opportunity to interact with you, to speak to you. And very important topic, which probably I'm going to discuss about, is how we enhance the quality of life when we do the microvascular reconstructive surgery. I think in present era, this microvascular reconstructive surgery is the biggest tool to fight the surgical fear. I'm going to talk about what is surgical fear is in the later part of my presentation. So I welcome you all to this presentation, and it will not be, very. There'll be a lot of pictures we are going to show you. Probably we are going to discuss how we have done, and I'll convince you at the end of the presentation that yes, any cancer patient with T1, T2 disease, we can give the best quality of life in all aspects. As Deepak said, that young man operated for cancer, nobody can make out. I think that is the beauty of we being maxillofacial surgeon, practicing head and neck oncology and giving the best of our results. Okay, Chirag, I'm not able to start my presentation. Click my presentation. Chirag, are you there?
Yes, sir. I'll just take access to your screen, sir.
Yeah.
So if you can accept.
Just 1 minute.
Yeah, now you can access it. ये आप बस ये open कर दीजिए. Yes.
1 minute. No. System preferences.
Yeah.
Just 1 minute. Some technical snag.
Yeah.
I need to do some security changes in the Apple.
So नीचे that lock button is there, na? So
Huh?
just click on that. You might have to enter your password.
Okay.
Unlock.
Then
You click on zoom.us.
zoom.us. Okay,
Yeah.
then.
And then lock it again.
Good, Chirag. Yeah, we didn't knew all these functions. We are.
I think that should be it.
Okay, so now how to get back?
I'll इधर नीचे है sir आपका presentation. It was on PowerPoint, right?
Yeah.
Here we are.
Yeah. Okay.
Chirag, you can mute my audio and video till the end. Let him talk peacefully. All right.
Okay, so we start. We are going to talk about the microvascular free flaps. Now, head and neck reconstructive surgery is a very challenging discipline. Now, as we know that this part of the anatomical structure deals with many functions. So you must have read about, the in your probably first year or in your first year of graduation about the anatomy of maxilla. The anatomy of maxilla is so complex. We never know कि ये उल्टा कैसे और सीधा कैसा है. It has got so many surfaces, so many processes, so many attachments. So this is how the complex anatomy of head and neck, and it's very difficult or it's very challenging when we try to reconstruct this with the functional anatomical reconstruction. So now when we reconstruct, we restore the functional anatomy and an important area where we need to achieve a balance between the swallowing, occlusion, deglutition, and the appearance, or you can say aesthetic. Now, all these years, since last 5 decades, PMMC flap, we call it as a pectoris major myocutaneous flap, has been, a kind of workhorse for reconstruction, because it was easy reconstruction. It was the same site. It can be done by same surgeon, but it carries its own disadvantages. So probably you might have seen people around you, people who have been operated for cancer, that all head and neck reconstruction was done by PMMC flap. They will have a lot of problems. They will have a lot of problems with aesthetics, functions. They always will have pain in their in the operated side. If we remove the mandible, put just PMMC, there will be deviation, occlusion will be gone. So there are a lot of issues which were with the PMMC flap. So there was a need of a better reconstruction, and that is how there was a need of there was an induction of microvascular free flap which have come. And in today's date or today's era, this has taken as the workhorse of reconstruction at many centers, and we are doing the standard of care microvascular free flap reconstruction for reconstructive these post-oncological defects. So let me take briefly into this reconstruction portion that you must have probably read, or same principle as we have read in our probably the dentistry. The principles of reconstruction is form, function, and aesthetic. Now, when we talk about form or integrity, so why it is important? As I said, these anatomical structures deals with different functions. So now, if I talk about lips, so lip is it involved with it's swallowing, it involved with the oral competence, with the speech. Many things are related to the lips. If you do not reconstruct the lip properly, what is going to happen? Patient will have drooling, patient will have difficulty in speech. 1 minute, I think it has gone. Okay. Patient will have difficulty in speech, patient will have drooling, aesthetics will be compromised. So same way, like lip, palate, again, if we operate for palate, if we do not do the reconstruction, there'll be a lot of regurgitation issues and voice problem with that. So like that, we have lip, palate, tongue. We need to replace, we need to reconstruct these tissues, this structure adequately to prevent all these problems. So second is the function. As I said, there are many important functions which are related to this maxillofacial or head and neck region. So this is something mastication. We are not going to get into details of this individual function because you all are oriented enough to know what is the mastication, how it helps swallowing, speech, facial expression. When we talk about facial expression, it's important is whenever we are operating a salivary gland disease, it is important to preserve the seventh cranial nerve that is called facial nerve. Otherwise, patient is going to have facial nerve paralysis that might compromise your aesthetics. So these are the things which are importantly we should be considerate when we are operating or reconstructing. So the best part is aesthetics. Now we being the maxillofacial surgeons, I think we are the best person who can recreate or who can give the best aesthetics when it comes to maxillofacial reconstruction. So earlier in our when we were students, probably a few years back, we have been taught as Deepak said, the textbook had written what which is since last 20-25 years we were reading the same textbooks. So this is according to the textbook, but now this is being changed. Now this is a reconstruction ladder. Now why it is called a reconstruction ladder? Earlier we used to think first we should go for primary closure, then a bit skin graft, then local flap, then regional flap, then free flap. Because probably 15, 20 years back, free flap, it was done by a handful of surgeons across India. But now, down the line, after 15, 20 years, probably this have changed. Now it has come as the reverse reconstructive ladder. Or there's one more terminology which has been used here is the reconstruction elevator. So many times a surgeon can can choose the reconstructive modality based on their skills, based on the availability and the best to the patient. So I can say according to the patient need, fits the patient best, a customized reconstruction can be done for the patient. But when we talk about reverse reconstructive ladder, whenever we are operating head and neck surgery or oral cancer, I think we are unfortunate that 70 to 80% of the patients comes on an advanced stage, and we need a bigger resection. Bigger resection means now if we take a 1 centimeter margin all around, we are going to destruct a lot of tissue. We are going to take out the mandible, we are going to take out the tongue, probably we are going to take out
message bhi kar diya वापस. You can carry on with the treatment, no problem.
So sorry, I'll just mute Deepak. Just
okay.
Yeah, sir, continue.
Done? Okay. So now, why do we need free flap as the first choice? As I said, our resections are very extensive. There are a lot of structures when we are doing the ablative surgery are being removed. And most importantly, all these patients who are coming on stage 4, they will require radiation. So the moment you give radiation, all the other modalities of reconstruction, be it putting a plate, putting free bone graft, nothing works. I say nothing works other than free flaps. Because these patients, when they receive radiation, everything goes. If you put a free bone graft, it will just resolve, it will go necrose. If you put just a plate, the plate is going to fracture. And there are a lot of issues which a patient may face. Ultimately, a doctor has to answer all those things. So keeping all those things in mind, we are doing free flap as our first option when we talk about the post-cancer ablative reconstruction. So there are various kinds of reconstructive flaps are available. So there are pedicle flaps and there are free flaps. So pedicle flaps means we can say these are loco-regional flaps. So according to the patient, at times we might use these kind of free flaps like forehead flap, PMMC flap, nasolabial flap, deltopectoral and latissimus dorsi. So these are the loco-regional flap which can be used for reconstruction. And we are today going to talk or discuss all about the free flaps, that how free flaps are being done, from where these free flaps are harvested, and what are the advantages of doing these free flaps. So we are doing radial forearm flaps, we are doing medial sural, we are doing anterolateral thigh flap, fibula, scapula, we are doing latissimus dorsi, we are doing rectus abdominis and iliac crest, iliac bone grafts. So now, before I get into the details of this free grafts, you need to understand the advantages. Because I tell you, whenever we explain about the surgery to a patient, what is the biggest thing he has in his mind? It is the surgical fear. Surgical fear is considered as one of the important factors for delay in diagnosis. People do not report to doctor, even though they know there's some problem. Why? Because they think, agar main doctor ke paas gaya, and if he says it has to be operated, what will happen to me? We know that everyone's face is his identity. So nobody wants to get operated on the face. So now the surgical fear is the one of the important criteria or important aspect a surgeon should explain to the patient. If you explain to the patient that post reconstruction, you will not have a major impact on your profile, on your function, And if you say with a confidence, keeping, with a good eye contact, patient always says yes. And he will be convinced, not only for surgery, but he will have confidence in you. Because this is one of the important things which, wherever you are practicing, if you tell your patients, even though you are not doing free flap, but if you can tell your patients that, see, you don't have to worry, this can be operated. And in case if you're worried about your aesthetics, there is a newer technique of advanced technique of reconstruction, which is called free flap, which you will not have any problem. So that is the reason that I have put few advantages for all of you to just have in your mind how or what are the advantages it carries, why we do so much of free flaps, or we do first choice as our free flap at our center. So now it is a two-team approach. So when we talk about two-team approach, one team is doing the primary resection, other team is raising the flap. So we save a lot of time. The moment your primary is out, your reconstruction flap is ready to resuture it there to fill the surgical defects. So it saves the time, improved vascularity and healing. Now, whenever we talk about wound healing, the important criteria is vascularity. So when we do the free flap, what we do is we are taking the vessels, so that is artery and veins, along with the tissue structure, be it bone, be it muscle or skin. We can have kind of complex graft also. So that vein and artery, we do the anastomosis with neck vessels. So it is like we cut the facial vessel, we have taken the artery from the distant side, and we do the anastomosis. That is called microvascular anastomosis, because your artery or your veins are hardly 2 mm or 3 mm. So this is all done under microscope. We use 10-0 ethylone for suturing the vessels. Now you can understand that this is a very, very technique sensitive, and it involves a lot of dexterity of your fingers to put the sutures adequately on the vessels, so that after you do the anastomosis, there should not be any arterial clot. No bony resorption. So as I said, if you put just a free bone graft, and if patient undergoes radiation, definitely it is going to undergo resorption. If patient doesn't receive radiation also, there are high chances this free bone graft will undergo resorption. The defect size. Now many times, we have seen in our practice that we are not concerned about the defect size. We have to treat the cancer at first instance. So whenever we take the margin, if I have 1 centimeter in my mind, as Deepak said, the minimum margin for Indian patient, we should have minimum of 1 centimeter margin on whenever we are doing the resection. So when we have an option of free flap, we are not bothered that ये defect छोटा होगा कि बड़ा होगा, whether I'll be able to fill it with the local flap or not. These things never come to our mind. So we are more open-minded when we are doing the resection, and adequate resection can be performed. Next is potential for sensory and motor intervention. So what do you mean by sensory or motor? So many times we can harvest the nerve also, and we can do the neural anastomosis also. Permit the use of osseointegration implants. So now it is a very important aspect for us to remember, or for us to know. If somebody is undergoing a mandibular resection and he has been put a PMMC flap, can you put the dental implants? Can you do the dental rehabilitation for that patient? No, obviously. So what is going to happen? That patient have to live with that compromised function throughout his life. So now these free flap or free bone grafts, what it makes is it gives a space for putting the dental implants in the future, where dental rehabilitation can be done and he can have improved quality of life. So wider variety of available tissue. As I said, whenever we are doing a resection of mandible, buccal mucosa, tongue, so now there are a lot of tissue. We need to have a lot of tissues to reconstruct individually. If we take PMMC flap, it is just musculocutaneous flap. You just have to fill in, that's all. But in this free flap, we can take bone separately. I mean, the same pedicle, we can have bone, we can have skin pedal, we can have muscle. So all three composite graft can be taken and it can be utilized wherever it is needed. Now it can be tailored to the match defect. आपको जितनी जरूरत है उतना ही आप डिफेक्ट क्लोज करने के लिए यू कैन टेक द फ्री फ्लैप एंड इट कैन बी कस्टमाइज. जितना जरूरत है उतना आप लगा सकते हैं. सो नेक्स्ट इज इट इज पॉसिबल टू रीडू. नाउ एज वी नो that oral cancer, if there's a stage 4 patient, there are 50% chances in next 5 years he will come with the recurrence. Recurrence can happen probably at same side, opposite side, and that is because of the field cancerization, as Deepak has already mentioned. Whenever a patient is chewing a gutka or any kind of chewing tobacco or smoking, it is not the one portion which get damaged. It is the whole buccal mucosa which is actually damaged. So there are high chances you are treated in one portion, you might develop a cancer, he might develop on the other side. So now you have done a radiation for first cancer. We cannot take local flaps there because once you have given the radiation, skin becomes very taut. So these free flaps can be used whenever there is a redo surgery. Very low donor site morbidity. Absolutely, if you see our patients, if you talk to the patient will say, अरे हमको तो कुछ पता ही नहीं लगता है कि हमने हमारा कहीं से ऑपरेशन भी हुआ है. You take any graft, be it your radial forearm, be it your medial sural, be it your scapula, fibula, patient have very, very minimal morbidity in that area. So now what are the limitations? Definitely everything, everything has its own limitations. So first is it's a technically demanding. You need to practice for hours and hours, days and days, years and years, because it is a very, very technique sensitive. You need to use 10-0 or at times, we can use 9-0 also, but you need to use 8-0, 9-0 or 10-0 to take the stitches on a very, very minute vessels. So it's a very technically demanding. You need to develop that dexterity in your hands to handle the vessels. Second, high success rate in the hands of expert. Once you have become the expert, I think the success of the free flap for our case is more than 96%, because many a times whenever we talk about the patients that we are going to do this free flap, there are 3 to 4% chances of failure. So now many people think that ये करने से तो fail हो जाता है, PMMC doesn't fail. But if it is done by the expert hands, the chances of the failures are very less. It's a team approach. As I said, the oncology is, it's a very, basically whole oncology is about the comprehensive as a team approach. When talk about the surgical aspect also, it's a team approach. So there's one team who's doing the resection, the other team who's doing the reconstruction. And OT infrastructure, yes, you have to have a good quality of microscope to do the anastomosis, to do the microvascular work. So these are few limitations. I think that is the reason that still in today's date, there are only a few centers who advocate the free flap techniques. If I say in Ahmedabad per se, there are only 20% of people who receives microvascular reconstruction. Rest 80% they receive just loco-regional flaps. So it's it's time for us to train ourselves. If you're a maxillofacial surgeon, any of you have trained yourself into the field of reconstructive surgery, because that is the need of an hour in the coming time. So now we are going to talk about common free flaps. How do we do it? And some pre-op, post-op results. So at least you have an idea that how these flaps are harvested, from where it is harvested, and what advantage or disadvantage it carries. So the first one is the radial forearm flap. This is a very commonly used free flap, or you can say it is a learner's flap. Whenever we start learning microvascular free flap, this is the first flap we try to learn. This is also termed as a Chinese flap because this has been started in China probably in 1980s. So this flap is basically a fasciocutaneous. From here you take it. I'll show you from which portion you take it. So this is where you take the radial. Based on the radial artery, there's a ulnar artery. So based on radial artery, you take how much ever is needed. You take this graft along with radial artery, cephalic vein, and vena comitans of the facial artery. So what is vena comitant? For your knowledge, I will tell you vena comitants are, there are usually two veins which are running along the artery. So that is called vena comitants. So whenever we are doing the anastomosis, we usually do two anastomoses, one with the cephalic and one with the vena comitants. So we are not going to get the details of probably the anatomical details. We are not going to get into anatomical details. So this is one of the harvested free flap photo. Now this is how we wanted to have it defect, which is a custom fit. We have taken the flap. You can see there is a cephalic vein and one the lower limb, or you can say that is the the radial artery with vena comitans. Now, what are the advantages? Now, radial forearm is, at our center, probably we have replaced this radial forearm free flaps absolutely with the medial sural free flaps because of few disadvantages which I'm going to mention it about. So, but we have few advantages. First is we have very long skin pedicle, easy repositioning. We can do in a two-team technique. We can take the nerve for the sense, for sensation, and it is very easily preoperatively we can do the evaluation by doing the Allen's test. But now, what are the disadvantage? Why we have discontinued this flap, or probably we have taken the medial sural as the first free flap and radial forearm as second. The first thing is poorly aesthetic donor site. I'm going to show you the photo now. What happens is whenever we take the graft from here, we have taken the fasciocutaneous graft, we need to put another skin graft, another split skin graft or full thickness skin graft here. So now there are two donor sites. One, we take the skin graft from the thigh or abdomen, we put it here, and this graft we are putting intraorally. So this mark will be there throughout the life. Now, how that mark appears, I'm going to show you in the later part of the presentation. So many of these patients, they will always say, "Sab ye mark dikhta hai." We ask the patient to wear, the sports band jo aati hai. Usually we ask patient to wear and camouflage it. But now with the other free flaps, I think this is not needed. So we are going to have a discussion about how these radial forearm flaps are being used for oral cavity reconstructions or head and neck reconstruction. So this is a case. Now you can see clearly that this patient comes with a lesion on the left side of angle of mouth, which is anterior buccal mucosa lesion. So we are not going to get into details of this resective surgeries. Now we have done the radial forearm flap for this patient, as I have shown how we have harvested, and this is the post-operative photo of this patient. You can see beautifully the buccal mucosa have been replaced with the radial forearm flap. It is so pliable, so easily, the patient can have, a very good competence with this free flap. This is the donor site morbidity I was talking about. That patient will have the skin graft mark always. So one is here and one is on thigh from where we have taken the graft. So there are two donor sites are there in this radial forearm flap. And this flap, over a period of time, it undergoes mucosalization. That means it appears like an buccal mucosa. Many a times there are hair growths in the buccal mucosa if patient has on the hand, but over a period of time that also disappears. So now second free flap, or we are talking about the soft tissue free flaps. So ALT, so that is called anterolateral thigh flap. So anterolateral thigh flap we take from the lateral aspect of thighs. So now what are the advantages? You can take a big flap. You can take जितना भी बड़ा चाहिए होता है आप, you can take a bigger flap. You can take skin, only skin, I mean fasciocutaneous. You can take along with the muscle also. You can take big chunk of muscle, so based on your primary defect, how much is being needed, you can harvest this flap. Secondly, all these free flaps, ALT free flaps, primary closure is done. So there's no donor site morbidity because we are doing the primary closure. Positioning, as I said, it's very easy, 2-team technique. One is doing resection, the other person is harvesting it. At our hospital, the moment our primary is done, sent for frozen, neck dissection is done, we are ready with the harvested free flap. So it saves a lot of time, it saves just, we can immediately, the moment the neck is done, we can start putting our flap and start with our anastomosis. So the disadvantages is many times, we get the pedicle length is, sometimes it's a shorter length, and other disadvantages, the bulkiness. Many times the patient who are heavy weighted, they will have big thighs. So many times it becomes difficult to harvest, customize, tailor according to the patient's, the oral cavity need. So that usually what we do is the thinning of free flap or thinning of ALT flap can be done. But definitely it's a problematic if the patient's thigh is too thick. Now we are going to have two case discussions. So one is this patient reported to us with a ulcer on lower lip, which is almost reaching up to the vestibule, and it was not eroding the bone; it was just lip lesion. So now what we have done, we have this is how we have marked. You can see we have adequately away from the skin margin, 1 centimeter away margin. This is how we have done the resection. We have removed the marginal mandibulectomy have been done for this patient. We have done bilateral neck dissection, and this is the specimen. You can see how far we are from the disease margin. We always take 1 centimeter away from the margin. It is a rule for us that we need to stay 1 centimeter away. We can be more than 1 centimeter, but never less than 1 centimeter. So now this is the markings of ALT flap. So anterolateral thigh flap. That's how we have harvested the flap. We have positioned the flap, and this is immediately post-op that we have taken the flap, we have covered intraoral, we have covered extraoral. Now this patient, as you can see, that patient was having extensive disease. That patient received the radiation, and this is the photo post 1 year of radiation. You can see the competence. The first thing what I was talking about is competence. You can see this patient can eat, this patient can drink. There is no drooling per se. So this patient competence is good. See the mouth opening. Now these are two important things usually which doesn't happen with any loco-regional flaps here. Either patient will land up in incompetency, either he will land up into the kind of trismus or decreased mouth opening. I think mouth opening is also a very important criteria which have to be considered whenever we are operating a patient, that make a bigger difference on quality of life post-operatively. So this is the patient. That's how we have reconstructed with ALT, and this is the 1 year post radiation pictures. You can appreciate, again I say, competency and mouth opening is the important thing which is worth noting on the slides. Now we have one more case. It's a very interesting case we had. we get these cases, we usually get very rarely. But this is an interesting case of fibrous histiocytoma of scalp. As Deepak has mentioned, that yes, we do deals with all head and neck cancers, probably except the larynx. We do all kind of resective surgeries, even the reconstructive surgeries. So now this patient came to us with this kind of presentation. So when we have taken to operation theater, we could mark, now we have marked 2 centimeters for this patient, not 1 centimeter, because this is an aggressive tumor. So we have marked this. You can appreciate our marking. This is this is the specimen. Now, even after being so away on frozen section, on posterior aspect, in the last photo, you can see there was skin, there was few tumor cells can be seen. So on the frozen section, we have again did the revision surgery till the time we get the negative margins on the skin scalp side. So now you can see there's a huge defect. So almost from this portion to this portion, everything is gone. Your bone is exposed, your calvarium is exposed. What reconstruction we are going to do it here? It was definitely a very challenging case. So how we have done is, we have taken ALT flap along with the muscle. Now, what we have done, we have spread the muscles. We have spread the muscles in the posterior aspect, and anteriorly we have taken the flap. Now, the important issue at this place was anastomosis. Your vessels will not reach from here to here, neck. We will not have this much of long length. So there was a very, we had struggled to do the anastomosis, and I tell you, we did the anastomosis with superficial temporal artery, and we have done venous anastomosis with supraorbital vein. Probably you might have read in your books, there's a small vein in superior aspect of orbit, that is supraorbital vein. We have used it for anastomosis, and God is great with us. We could do successfully, and this is how the patient result after 1 month of the surgery. So this is how you can see we have put the skin graft on the muscle. We have covered the complete scalp has been covered, and we could cover the calvarium. We could reconstruct it adequately. So that is the advantage of doing a free flap, with such a precisely. So this is this is the primary defect. As I said, it is just closed primarily and doesn't have any donor site morbidity. So now I think you're not getting bored, because now we are going to talk to you about a third flap, which is medial sural free flap. Now, see, the idea behind discussing with you all about this free flap is, as a doctor, we should know. As a doctor, we can tell our patient that this can be done, this can be done. The options can be given by you, and that can be, we can give in detail, but at least patient should know what is the best surgery for them. Because what happens is, the people who are not doing free flap, they will not tell about the free flap to the patients. There's nothing called free flap. See, a patient doesn't know what is a free flap. And many a times what happens is, patient underwent locoregional flaps, he have many compromise issues, then through some person they got to know about the free flap, they visit us, sir, ab hamara kuch kar do. And frankly, I tell you, it's very difficult for redo free flap surgery just for facial corrections, and that can be only done probably after 2 years of post-operative period of the patient. So a patient should know what is the best available for him, and then let him decide that whether he wants to go for free flap, whether he wants to go for locoregional flap. It should not be decided by the operating surgeon कि मैं तेरे को free flap करूँगा, तेरे को local flap करूँगा, और तेरे को skin graft करूँगा. I think that is very important thing. We should leave this decision to the patient, giving all the available options, and that is what we are doing. We give all the options. We are not hard and fast about doing the free flaps, but yes, we do give all the options. We tell about the advantages, we tell about the disadvantages, and let the patient decide and revert to us, sir, I want to undergo this free flap or this kind of flap. So now we have a very interesting flap, that is medial sural artery perforator flap. Now, as I said, that radial forearm flap is being, we have slowly and slowly we have replaced with this flap because it has its own advantages. So I'm going to have a small discussion about this medial sural free flap. So now we are going to, I'm not getting into the details of this flap. Only issue with this flap, why not many people are doing across the country, is the vessel are very thin. Secondly, it comes out through the muscle. So you need a very, very, very precise dissection of the pedicle from the muscle, and the vessel diameter is very less, artery is hardly 1 mm, so it is difficult for anastomosis also. So this is not being routinely being done. There are a handful of surgeons who are doing medial sural free flaps in this country. So now we are going to have two small case discussions. Like this is the patient. Usually you will see, you might have seen or you will see in your coming practice these kind of lesions. जहाँ आपको लगता है एक छोटा सा ही तो lesion है. There's a small lesion there in the, you can see in the on the alveolus or GB sulcus. Now we have done the biopsy. This came out to be positive. So don't think that's a small lesion, that means he will require a small surgery. No. Again, that is a wrong concept. I think what, again I say, what my boss used to say is, you need to treat stage 1, stage 2 patient adequately. You need to do the best of reconstruction because these patients are going to live long and definitely they require a very good quality of life. And that is where we do, that's how we have done the surgery. So this you can see adequately, even though it was a small tumor, we have done the marginal resection. We have removed a cuff of tissue along the, along with the your ulcer. And this is the medial sural. This how we have raised. This you can see in the second slide, probably if you can appreciate, there's a bluish line there, you can see it's a bluish thread. So that is the pedicle. It's a very, very thin pedicle. If you still want to appreciate, you can see in our photo that this small thread, it is containing one artery and two vessels. Now imagine getting, separating these vessels, separating all three vessels, doing anastomosis. Definitely it requires a lot of skills. So now this is post-operative result. As Deepak mentioned, this patient, he comes and always he says, साहब मेरे को देख के लोग कहते ही नहीं हैं कि मुझे कैंसर का ऑपरेशन हुआ है. Now that is, I think, the best compliment every doctor want to hear after cancer surgery. कि साहब मेरे को कैंसर का ऑपरेशन हुआ है, लोग कहते ही नहीं. And that is where you can see we usually don't do the lip split. We only use the neck incision, and that is how our reconstruction is being done. So when we talk about the quality this patient has, this is the best quality of life probably we could have given to him. We have one more case because these are the common cases. We have kept very common cases, no high funda, no advanced cases. So we have kept two cases very commonly. You will see a small ulcer in GB sulcus, or you will see a small ulcer on tongue. Now this patient comes with a small ulcer on the tongue. Small ulcer means probably it is 2 into 2 centimeter or hardly less than 2 centimeter. Now many people think that ये तो छोटा सा है, इसको तो ऐसे ही निकाल देते हैं. As I said, no cancer surgery is small surgery or big surgery. Cancer surgery is a cancer surgery. So for this patient, again, what we have done adequate partial glossectomy is being done. We have done the neck dissection. As somebody was asking how many levels we need to clear. For tongue, usually we do level 1 to 4 resections. Level 1 to 4 nodal dissection is being done. We call it as extended supraomohyoid neck dissection. So now there are two options when we talk about this kind of resection and reconstruction. We can just primary close it. Okay, primary closure. Now what happens with primary closure? We need to deviate the tongue. The tip will get deviated to one side. Secondly, the bulk will be in the center of the tongue. So there are a lot of issues. It is difficult for you to probably imagine that what if this patient undergoes a primary closure. It is difficult for you. But we have seen that this patient, if you do a primary closure, there are a lot of issues. Yes, this patient, we could have done the submental flap, or we could have done any other flap, local region flap. But as I said, patient was interested. Patient said, I want to go for free flap surgery. Now, this is the kind of margin we mark it. You can appreciate our markings. Again, I say more than 1.5 centimeter in tongue. This is the primary defect. So even though your disease is so small, your disease is 2 centimeter, you need to take it out 1.5 centimeter on this side, 1.5 centimeter on this side. So you are actually you're removing around 5-6 centimeter of tongue. So now when we take out the 5-6 centimeter of tongue, it is important to reconstruct it. So what we have done, reconstruction for this is, we have taken this medial sural free flap. Now in this photo, you can appreciate better this how we do the flap dissection. This is a medial sural flap. This is the skin. It's a fasciocutaneous flap. So this is the post-operative result. Now you can see the patient tongue. You can see the midline. The midline is exactly, the tongue is not deviated. Now from wherever we have done the surgery, it is, we have placed a medial sural free flap there. So patient doesn't have any difficulty in deglutition, mastication, speech, anything. So that is where our principal have taken into consideration and done the best of reconstruction. We have presented our paper, in Seoul about comparing the medial sural and radial forearm free flaps. So now we'll come to the bony reconstruction. So I hope you're not getting bored. Probably, so we talk about now. We are going to talk about the bony reconstruction, and we'll take up your questions. So bony reconstruction, as I said, it's a very important. Now mandible is a single bone. We say, we have read in our anatomy, this is the only strongest single bone in our whole body. So whenever, and it has got a dentate, or it has got the teeth attachments. So whenever we are doing the resection, what is going to happen is, we are not removing the teeth, but your mandible will get deviated if you do not reconstruct it adequately. So there are various techniques of reconstruction. Usually in earlier time, what people used to do it, they used to just put a plate. कि ठीक है चलो plate लगा देते हैं बाद में देखेंगे. They used to put a plate and then put a PM. There were many things, many things were being done all these years. They used to take rib graft or take iliac graft. All these things have been done. But now, only best possible modality in today's date across the world, I say, is the free fibula or free scapula bony reconstruction. So fibula is, we have got two bone. Fibula is a non-weight bearing bone in the leg, which can be utilized. It is based on peroneal artery. So we are straightway will get into two cases of fibula, probably one case of fibula and two cases of scapula. So this is the patient who has reported to us with the ulcer on the left side of buccal mucosa, RMT region. So we have removed almost, crossing midline from canine region to the, you can say, subsigmoid. We have removed the whole mandible. It's definitely an extensive surgery. It has been done. Now what happens if you do not reconstruct these anterior segment with free fibula or any bony graft? So now you know there's attachment of genial tubercle, there's attachment of important muscles of tongue that is called genioglossus. Now genioglossus muscle, it is attached to this genial tuberculus there. So what happens, the moment the attachment are being cut, the tongue falls back. So it is important for us to reconstruct this defect. Whenever we are doing a bony reconstruction, we need to reattach these fibers of genioglossus to newly reconstructed bone. Otherwise, patient throughout his life is going to have gag reflex, is going to have difficulty in speech, difficulty in swallowing, difficulty in eating. And in these cases, if anyone puts a PMMC flap, you can imagine his quality of life. I say he cannot eat throughout his life. I have seen many patients who have been operated with central arch, just putting a PMMC flap. Patient have to lie down to drink something to fill up their stomach. I think that quality of life we do not expect anyone to have. So that is where the role of free fibula comes and gives, enhances the quality. So now you can appreciate our results, that this is the pre-operative picture of the patient. This is post-operative picture of the patient. Can you see any major difference in profile, aesthetic? Absolutely. There's a very minimal morbidity you can see. Mouth opening. As I said, mouth opening, beautiful mouth opening this patient has. And this patient has teeth on the other side, and there's a fibula is placed on this side. So there is always an option in the future that dental implants can be done for this patient. And as a max spec surgeon probably, or as a dental specialist, you people have to take interest in putting implants into this fibula and rehabilitating these patients, because when you're putting the fibula, still our work is 50% done. When we do the dental implants, I think that is where we can say 100% work has been done. So you people need to take interest, you people need to take a training, further training in putting implants into dental, in the reconstructed bone, be it scapula or be it fibula, and probably you can add on to the patient's quality of life. Now, we are going to talk about the scapula free flap, because this is one of the free flap which are being done by our team. And we have done, last year, we have done highest number of scapula free flap across India. And we are doing regularly for our patients because of its own advantages. So we are not going to get into details of, the scapula free flaps. I'll just skip the details. But I just want to show you that scapula, it's a wing bone. It's present on back side. There are two scapula. It is near to the shoulder joint. So you can see a picture of scapula here. We can take the scapula lateral border, and at times, if it is needed, we can take the tip of scapula. Also can be used for reconstruction, especially for maxillary reconstruction. Scapula is the best solution in today's date. Now we are going to have two cases, important cases. This is the patient who have been operated earlier, and you can see there's a mark, where there's a mark on left side. Nasolabial flap has been done for this patient 1 year back. Now this 4 years back was done, and patient reported to us, when we have seen the patient, there was an ulcerative lesion in lower GBS, or you can say the alveolus where the nasolabial was placed. You can see clearly in this picture. Even though it was a small ulcer, but it was just sitting on the alveolus, and there was a bony erosion. So we had planned for segmental mandibulectomy for this patient. Now, for this patient, we have taken only the bone. We have not taken the skin pattern. So, as I said, you can decide it based on need. You can take only the bone. You can take bone and muscle. You can take bone, muscle, and skin pattern. So it depends on your how much defect, how much tissue is needed for reconstruction. So now you can see we have taken, this is a scapula bone and this is the vessel. You see a kind of tail thing, this is a vessel there. So these are the harvested pictures. You can see in the third picture that there is a defect. You can see there's a bony defect. You can appreciate. Now we have done the scapula free flap. We have fixed it with the plates and screws and covered it with the muscle we have taken it. And this is the post-operative result. You can see we have we have put the muscle in the intraoral, which has undergone mucosization, and this is the post-operative donor side healing. Absolutely, patient doesn't have any problem when it comes to scapula harvested. And the important thing is your scar mark is totally hidden in your cloths. It is not visible there. So this is how your you can appreciate this is a pre-operative, this is a post-operative. Now we have tried to maintain the function, aesthetic of this patient. You can see pre-operative, post-operatively. If you superimpose, you will not find major difference for this patient. So the advantage of scapula, when I was being trained at, I was trained from Germany for the scapula. They used to say the scar hides in the bra line. So whenever we are doing the resection from the leg, many times the people, they are not the foreigners or, the people in Germany are not very much comfortable with the scar on the leg because they don't want, they cannot wear the shorts and other things. There were a lot of issues were there. So Europeans and the Britishers are using scapula free flap as the primary flap, giving an edge over the fibula free flap because of its own disadvantages the scapula carries. And we are also trying to popularize this technique in India with the scapula giving an edge over the fibula. So now this is very important thing which you need to see the X-ray now. See the mandible, how the new mandible have formed. Can you see even a 1% difference in this mandible? Beautifully, the scapula, it unites because scapula is kind of a cortical and marrow bone is there. Exactly like how the mandible is there. The fibula is a pipe bone. It doesn't have a marrow. It's a cortical bone. But this scapula has got a cortex, it got a medulla, and that is how the post-operative three-dimensional result. You can see beautiful scapula which is adapted to the mandible. I think that is how we appreciate it, that scapula gives a beautiful result. So one more last patient we are going to discuss. So this is a case, again it's a locally advanced patient reported to us with a big defect, which is lower alveolus, chin, everything is involved. Now, ideally speaking, if I have to operate on this patient, I need to do 2 free flaps. So because there's a mandible there, there's an intraoral defect, there's an extraoral defect, the whole lip is going to go, chin is going to go. So such a big defect, we have done many double free flaps. Now the scapula, if we use it for bilobe technique, this alleviates the need of the double free flap. Now this is the picture of clinical picture. You can see the lower anterior is completely eroded. The buccal cortical plate is eroded. This is the 3-dimensional picture. I want you to keep this in mind, the 3-dimensional picture, because I'm going to show you post scapular reconstruction also. So keep in mind, keep looking at this picture that we have exactly reconstructed this scapula, the resected bone with the scapula. This is a 3-dimensional view of view of scapula. Usually we are doing 3D technique, 3-dimensional. I mean, we are using 3D models for all our reconstruction. We do on table preparation or planning, how much scapula, how we have to do everything. We plan it on table before we enter into our operation or operative theater. So now this is a operative picture. You can see this is our tumor. We have gone 1.5 centimeter beyond the tumor. We have removed complete lower lip, alveolus, chin, everything has been removed. And what we have done here is we have taken scapula bone along with two paddles. So when I say you can take composite free flap, means we have taken two paddles. Now, why we have taken two paddles is, now bone is going to do the reconstruction of mandible. Now there is a defect in buccal mucosa, there is defect extraoral. So what we have done, we have used this one pedal intraoral and one pedal extraoral for reconstruction. So now there is no need of doing another free flap for this patient. And this is the post-operative result. You can again appreciate that this patient has got a preferably good competence. Now, I told you to remember the mandibular anatomy. Now you can appreciate in this picture that how we have put the scapula bone. So you can see exactly, as I said, we do three-dimensional, 3D models, we do it. And that's how we have pre-plated. After surgery, we plate on mandible and we fix the fibula like this. So the anatomy of the mandible, we have mimicked it exactly according to how it was earlier. Again, we have presented our this paper of fibula versus scapula at one of the international conferences in Argentina in 2 years back. So now, what is the need of an hour? So till date, I think being max spec surgeon into oncology, we are just doing the reconstructions. So now we are looking forward to put dental implants into this into this reconstructed bone. So osteo-integrated implant into this reconstructed bone will definitely, it will add on or enhance the quality of life, and that is where our role. Any of you have any interest in this aspect, this field, you can always contact me, contact Deepak. Get yourself training. Nothing will happen without training. Get yourself trained. If you want to go abroad, if you want to attach with anyone, we have all options. Only your intent should be there to get training into oncology, for even for putting implants. So I think it is important for us now that some of you should take up this field where you are doing dental implant restoration for these these reconstructed bone, and then only we are going to give 100% result. It is still, I said, we are giving 50%. If you do the dental implant, मैं भी सीना ठोक के कहूंगा कि हमने 100% result दिया. So future directions, probably there are things are going on for tissue engineering. Again, I will not get into these details, but tissue engineering की हम लोग lab के अंदर we try to make the bone and then put that bone. There are various research is going on. I think tissue engineering is one of the things which we are looking forward in the coming time. So before I conclude my talk, I have probably I have said 50 times in my presentation, quality of life, quality of life, quality of life. Earlier, people used to treat just the disease, but now we need to treat the patient. We need to treat the patient emotions. We need to treat the patient adequately so that he maintains a good quality of life. So the quotation goes, a quality of life is more important than life itself. So with this, I think I would like to conclude. I hope you are not getting bored. Chalo, Chirag, I think I'm done. Any questions I would love to take, and let Deepak come in. I don't know how. I'm very good at presentation.
I think people from all across are also appreciating the depth in which you and Deepak sir went. Deepak sir, if you can switch on your video as well. Sir, there was just one question for you, Shakti sir.
Only one question now.
Yeah. Because first question was that in radial forearm free flap, in the first case which you showed, were dental implants placed, and if yes, like how were they placed?
Sorry, I didn't the question. I didn't get the question.
Radial forearm free flap, in the first case which you showed, how were the implants placed?
No, implants are being placed in the native mandible. Implants are not.
It's basically the tilted protocol.
Radial forearm. So, sorry.
Is it the tilted protocol, the tilted implant protocol, right?
No, I am not doing implants into this. I know still the reconstructed bone, but there are there are papers which says we can do the reconstruction. I mean, we can put the dental implant into the marginal mandibulectomy defects also. Yes. So it is not into the radial forearm flap. It is into the native mandible, whatever is left behind. We can put the dental implants into those that native mandible, and we can rehabilitate it.
Right.
Shakti, I mean, I should first congratulate you. Such a phenomenal, work you are doing. I am feeling very weird after seeing your presentation. A really, really good work. Phenomenal. It's that's why we wanted this meeting because these are the international guidelines to reconstruct these patients. What Dr. Shakti is doing. So we have not told you something what we have been taught. We have told you something which is done all over the world. He trained for a single flap from Germany, if I'm not mistaken, right?
Yeah, correct.
It takes a lot of effort to even go 100 kilometers away. In today's world, I don't know. I mean, I feel we are probably 12 years ahead of all of you, 15 years, 12 years probably. Nowadays, we don't feel that, people feel that much of intensity to learn to go this far. I mean, this is my personal experience. Imagine a guy leaving the country, going to Germany, God knows for how many months, just to learn a single flap. I mean, hats off.
I was there for 1.5 months.
Yeah, and that's why, what, let me tell everyone what Dr. Shakti is doing is something which is at par with any international center in the world. This is what is done for these defects. There is no shortcut, because unfortunately, sometimes I am having so much of unnecessarily, load. So we might have to sometimes, do things which are little just to probably, patients are very poor and we do not have resources. And sometimes I have to do a free flap myself. It's rare. I am not even 1/10 close to Shakti, but I started doing them and I felt, oh my God, you need too much of patience and you need too much of dedication. So really phenomenal. I mean, good.
Thank you, Deepak. Thank you for kind words and compliments. Thank you.
I'm proud that you came for this talk. Even I think all these boys, Chirag, Parth, we have seen reconstructive surgery, which it's much probably higher than what most of us have seen. What do you think, Chirag? It's really good.
So you remember that long time back in the OT, we were discussing scapular flap when we were attending a session of EOMSI, and you were like, "Arey, I don't know much about it."
Not only gracile and all these other things. This is very the anatomy of the inferior extremity, the orientation of the vessel. So phenomenal work. Very nice. Very nice. Good.
So
thank you.
Thank God I don't do micro much now. After seeing how much effort it takes, oh my God, it's really something. Okay, Chirag, any questions more?
Sir, you answered most of them live.
Yeah.
Yeah, so I think that was good. Only one, everyone is asking that everyone is confused with maxillary reconstructions. Like, what is the option?
Please. Let the doctor.
Only maxillary reconstructions.
So the master of reconstruction should talk about it.
Okay. So see, earlier times, what we used to get is obturator. That was the choice people used to give. We do the maxillectomy, you go and put the obturator. But now we have not given any obturator to any of the patients in the last 5 years. So the maxillary reconstruction is being done with, we do the soft tissue free flap and we do the hard tissue reconstruction. So there was I couldn't put my maxillary reconstruction scapula into it. So when we do the maxillary reconstruction, soft tissue, usually we are using ALT free flap, and we are using radial forearm for if it is going to the posterior side of the palate. When it talk about the bony reconstruction, we are using scapula for bony reconstruction. So the advantage what I tell you about the scapula is, see, scapula bone, if you see the anatomy, it has got a lateral border which is thick, and the moment it goes to the medial side, it becomes thin out. So exactly it mimics the palate. So when we doing the scapular reconstruction for maxilla, we don't take any skin paddle. What we do is we take only the bone with a cuff of muscle. Now we take bone, muscle, and we fix it. So once we have done the primary resection, we fix it on the palatal side, we fix it on the buttress region, and probably nasal buttress. We do 3-point fixation. And the advantage is patient doesn't have skin taste in the mouth. This is something, if you ask your patient, any patient done reconstruction, the skin taste and hair growth is the biggest problem. They will not be satisfied any day. Whenever they are walking into OPD, the first thing they will say, "Saab ye baal adte hain, wo katwa do, kaat do, nikal do, kya karo." So, that is that one thing. Second, the skin taste. So I think with using the scapula without putting the skin paddle, that is the best reconstruction. If I show my cases where we have done probably more than 32 scapula free flaps, and in that there were 12 to 14 cases were maxillary reconstructions. So if you see those patients, you will not be able to differentiate that this patient has undergone some reconstruction. So your complete muscle undergoes mucosalization. So scapula and at times fibula also can be used for maxillary reconstruction. But as of now, we are using more of scapula. We have done fibula for maxilla for only 2 cases, wherein if the defect is, there's a lot of defect. So we reconstruct using the fibula also. So 2 modalities: soft tissue, hard tissue. Soft tissue, ALT, radial forearm or medial sural, and hard tissue, it is fibula and scapula. That is how. But maxillary reconstruction has to be done. No obturator techniques. I think it is very. I don't know how far we are right, but it becomes a bit tedious for a patient to wear and other things. I don't know how far I'm right. Deepak is going to comment.
Okay, Dr. Shakti, do you change the position of the patient when you have to change the position after resection for harvesting?
Yes, we do. So what we do is, once the primary is being done, so we laterize the patient and we do the harvest.
And you paint and drape these patients again.
So what you do is we put the hyoban. Hyoban is the so we just cover the hyoban with the neck and the primary. We change, get back to the supine position, then we start operating. Probably we are also in a learning phase. In coming time, there is a center in Australia where Jonathan Clark, they are doing as a single team technique. So probably in coming years we will be able to develop the single team technique for scapula. But as of now, we are doing changing the position.
Okay, and how do these patients post-surgery sleep? They can't sleep on the back, right? I mean,
no, they can sleep.
They don't feel pain, anything like that,
No. No. Absolutely no pain.
Or something, sir?
Sorry?
Do they use a water bag or something like that, or it's a normal?
We just put a drain, and which has been removed after 4 to 5 days. Okay. And after 5 days, patient starts on the physiotherapy. Physiotherapy means the hand movements.
Okay, this was my next question. How do they do with the the shoulder movements and all post surgery?
Yeah, so after 5 days we start with the shoulder movements. So we have a trained physiotherapist. So after 5 days he comes in and he starts with the physiotherapy for these patients, and which is being carried for another 2 months. But down the line, patient absolutely doesn't have any deformity or any morbidity, I say, when it comes to the the movements of the scapula.
Okay, so I think phenomenal presentation. So what we'll do
Very
now,
good session,
we
sir.
we will just make the final remarks. I think Dr. Shakti can start, and then I, and then probably you for your, and Parth can say something.
Sure, sir.
So all of us can conclude. And if you have something which we have missed or you feel was not clear, our personal numbers you can take from Dr. Chirag and Dr. Parth and
Everyone
Saurabh.
has my number. So you
Yeah.
just text
So
or WhatsApp. I can share it anytime.
right. So we will try to get some more good seminars. See, it's not about organization. These boys are just, they cleared post graduation and they're trying to do all this for all of you. And we had good numbers today. So it's a good thing. And they will be, I think, very soon there with one more, subtopic of surgery or something which is important to know. And I think Shakti can start and we can conclude the meeting then. Okay, Shakti, take away message
Yeah,
for,
take
to all
away
the
messages.
youngsters.
So it's very important that you should know what are the surgical options available, and please help patient in fighting against the surgical fear what a patient is having. So don't try to push out the patient just saying it ki aap abhi aap chale jao, or go to civil hospital, go to this hospital, that hospital. Try to guide a patient, try to counsel a patient, sit with the patient. Probably he is not going to pay you anything much, but definitely you are going to carry a lot of things. You are going to, you are going to have a lot of advantages. So what you need to do is counsel a patient well regarding, if biopsy is already done, counsel regarding a, regarding the surgical outcome a patient can have. Make him fight the surgical fear. Please try to take away his surgical fear. Treat the patient, not just the disease. Keep that in mind. So with that, I think I'll like to conclude. Over to Deepak.
Okay, so I totally agree with Dr. Shakti. And, my biggest fear is, we have this fixed mindset up, Chirag, that, a specific center or specific person or specific, it's not about the specificity. See, when you refer someone, he needs urgent surgery in cases of cancer. So don't waste his time. Don't send him to places where people are extremely busy and they have no time for your so-called patient. And don't expect anything special. They are going to treat him or her as another patient. That's all. So you need to know the people who are doing good work. They know their stuff. Approach them directly, like area wise, probably Gujarat. This Dr. Shakti is there, and there are 2 3 very good maxillofacial surgeons who are doing head and neck work. Rather than sending to some institute where the waiting list is for 100 years, by the time the relatives also get recurrences, forget about, forget about patient. So it's just waiting and waiting. They're sleeping on the road. It's a very bad scenario. So my last my what I want to say is, please think like scientific people. Come out of this fixed mind setup and try to send them to people who know how to do it so that it can be sorted the problem. Otherwise you will lose the patient and the family, and probably generations will suffer in the future. Cancer will kill you. COVID may or may not, but cancer definitely is going to kill you if you don't treat it. All right. So this is my last thing what I want to say, and probably Chirag, you want to say something, and Parth, and if Saurabh is there.
Yes.
Saurabh is
Yes.
still operating.
Saurabh is operating.
Yeah.
So Chirag, do you
So
feel?
just
Bol Parth, bol.
sorry. So just want to like to thank Dr. Shakti and Dr. Deepak for this excellent and wonderful informative session. Actually, one of the comments I read was we've learned more in these 3 hours or 2 hours rather than 4 years of maxillofacial residency. So big thank you to you guys for sharing whatever you all have experienced so far in your field. Thank you so much. And now over to Chirag, whatever he wants to conclude.
Yeah. So thank you so much. And I think it was Deepak sir's effort, of actually telling me ki ye karte hai ek aur session, and getting Dr. Shakti on board, and then Parth and Saurabh also supported in this. And I think we had over 200 registrations, but unfortunately not everyone could join. And so we were full in when we started. We were full. Like people
Chirag, it's today's generation. Shakti goes to Germany to see one film, and people don't come to sit on the computer for a webinar.
So actually, what had happened was, so we had 100 people, and people were calling me. I'm not able to join, but then someone had some internet issue, something like that. So at the end of the day, more or less throughout the presentation, we were 90 odd, which is I think pretty good.
No, it's not about numbers. Even if you, me, and Shakti and Parth would have been there, we
Exactly.
would have had good fun.
It's not about numbers,
Yeah,
but
yeah.
if
At
these
least
people who
something
have
someone-
attended, if they take the message, I think that matters, that how many people take message from this webinar.
Okay, great. Thank you, Shakti. Thank you,
so much,
Chirag.
Thank you so much.
And we will definitely meet very soon with another lovely topic. Probably we both will not be there because we don't know anything else in our specialty. But
Okay,
we'll have some
so,
good.
Akshay Deshpande sir is also connected.
Oh, okay.
Yeah, so Dr. Saurabh, he is operating right now, so he's just asked one of the staff to connect to the OT. I think they are doing an ALT.
Okay.
So this is something bonus if everyone wants to see.
Yeah. Akshay, hi. Akshay is a phenomenal head and neck reconstructive surgeon. I mean, he does a lot of my cases, and he's somebody to look
Hi,
forward.
sir.
Hi, Deepak.
So
Very
this is
nice presentation. Huh?
bonus
Dr.
content.
Deepak, Dr. Shakti, very nice
Hi.
presentation. Huh? I'm listening all you.
Oh my God! Thank you so much.
Nice listening you.
Thank you, sir. Thank you, sir.
Cheers.
Thank you
Thanks,
so much.
Akshay.
Thank you.
And,
Take care.
Bye, Saurabh. Thank you so much.
much.
Bye,
Bye,
bye. Bye, see you guys. Bye, see you guys. Thank you.
Yeah, that was interesting. Okay, so I'll disconnect everybody now. Saurabh,